academic detailing from those first studies was about solving, even though it had academic in the title, it was about solving real world problems. And that is what we need in this time when there is so much about the real world that feels challenging, is that pragmatism combined with the intellectual rigor that continues to hold ourselves to high standards, even when we see all those discouraging words that people put in the chat waterfall, that we can have high standards, that we can reach across barriers and across differences to bring folks of good purpose together, and that we can do it in a way that's engaging. And so hopefully with sort of those things in mind, we can all just be appreciative, as I always am, to have a chance to learn from Jerry once again this year as he speaks to us about provenance. Jerry, take it away.
Okay, thank you very much, both Bevan and Mike, and thanks to everybody that has turned up in these complicated times for this annual event, which has really become something that is really very remarkable too. I never would have dreamed in 1979 when I got my first grant to do this that we'd be here in 2026 with such a wonderful national and international community of people doing such great work in so many different ways all around the country and the world. So thank you all for being there. Thank you, Mike and Bevan, for that kind introduction. I feel like I can't possibly live up to the intro, and I might just say thank you and goodbye, but I do want to do my part because I care a lot about this organization and all of you. As Mike mentioned, he and I worked together for about 87 years, it feels like, over in our division at the Brigham and at Harvard Med School. And he has always been a reliable and capable and inspiring colleague, even though he has gone off to other pastures. We are still very much in touch. So yeah, let us move on, Bevan, please, to the next slide. You should always, of course, expect a second slide that talks about any disclosures or financial conflicts of interest. And mine is always very simple because I don't have any. That neither I nor anybody at our Division of Pharmacoepidemiology at Harvard and the Brigham accept payment for consulting with any pharmaceutical company. I made that a rule when I first set up our division, and it is unique in the Harvard medical community, but I think it has stood us in good stead. And we have the same rule at ALOSA that none of our core people have any connection to or accept any funding from any pharmaceutical companies. And ALOSA, of course, is a not-for-profit, and I don't get paid anything for what I do there. Next slide, please, Bevan. Okay, so I'm thinking, what we do basically is communicate. And as I will give you a sort of slide tolerance test for the next few minutes, as many of you know, my wife Karen had been ill and has had a wonderful recovery thanks to some stem cells from our son. And after a year of being confined to quarters, we finally were allowed last month to travel by her oncologist, who gave her a clean bill of health. And as a result, I will be showing you some pictures because I'm always thinking about academic detailing and ALOSA and NaRCAD every minute of every day. And we're in the British Museum, I think, where we saw this tablet from Sumeria that is probably about 5,000 years old. And it struck me that this urge to write things down and then communicate them to other people has been with us for many, many millennia. And that this is, in a sense, a continuation of the Sumerian tradition of writing down important information to share it with others. Next slide, please, Bevan. Okay, so Provenance is the title, and those of you who've taken a look at the blog, one might think that it's a cool place in the south of France, or the idea that there is a all-knowing being watching over us, but actually it is not either of those. Those sound like it, but they're not. It's really, where something came from, whether it's a work of art or an idea or a paper or a work of literature. Who created it originally? Whose hands did it pass through, and who is purveying it to you now? And this is, of course, one of the most important things, especially in this bizarro world that we are now living in, where ideas come apparently from nowhere and then get preached from the highest prominence of national podiums imaginable, and as if they were true. And it has forced all of us to really think about, well, where did that idea come from that vaccines cause autism, or that you can cure it with leucovorin or any of the strange things we're hearing on our TVs from the head of the country and the head of our health apparatus, uh, but also at a more sophisticated level than that crude garbage. When we hear about the best goal for hypertension treatment or what is the utility of a new class of drugs for diabetes, I think that everybody in this conference is always thinks to themselves, well, who says and what's the evidence and where did it come from and who put it together and who's giving it to me? I think one of the reasons that people have a fondness for academic detailing is that we take very seriously where did the evidence come from and who's purveying it. And I think that's, as I'll say in a couple of minutes, one of our real secret superpowers and strengths as well. And it's more obvious in the art world where something is purveyed as a work of art that isn't, or even worse, as a work of art that is genuine but somehow was stolen from its original owners, and that theft has become obscured over the decades and nobody really wants to talk about it. But again, the theme of where did this come from and how did it get to me is a vital part of any kind of communication, particularly in medicine. Next one, please. Okay, so for clinical evidence, we have ways of, at least have had ways of making sure that a piece of medical information is true. One of the first things that I look at, and I suspect many of you do, is where was it published? And the proliferation of literally hundreds, if not thousands, of strange new things calling themselves journals that is unprecedented in my experience and has really taken off in the last couple of years makes it a bit harder. So if it's in the New England Journal or JAMA, one can feel pretty good about it. But my spam filter at work is literally full of the most common thing in my spam filter is notes from somebody I've never heard of that usually begin greetings of the day, indicating that they're perhaps not native English speakers. And it goes on to say that I have an opportunity to publish in some journal I've never heard of, and it will only cost me X thousand dollars. And that makes it harder for unsuspecting docs or other prescribers like nurses or pharmacists to be able to know, well, it was in a journal, but actually, was it really a journal? So where was it published? Who wrote it? It helps to know that these are people who've been around the block a couple of times and actually know what they're doing. But the most important, and the reason it's in bold, is what was the methodology. And at the end of the day, whether or not it is sponsored by the NIH or a drug company or anybody, the most important thing is how was the study done, whether it's a trial or an observational study. And Aaron Kesselheim, my beloved colleague over at the Division of Pharmacoepi, did a study a number of years ago that I may have mentioned previously to some of you, in which we did a randomized study taking the exact same abstract and showing it to a panel of several hundred internists and randomly changed whether it said the study was supported by the NIH or by a drug company or didn't indicate who supported it. And to our disappointment, merely saying it was supported by a drug company made a lot of people not believe it. And I think that is going too far in the opposite extreme. We have a lot of good knowledge that does come from industry supported studies, but they are perfectly done and the findings are important. And so we want to strike a balance and really focus on how is it done rather than who paid for it. And one of the advantages, as I note at the end of this slide, is that we really can all come into our doctors' offices or virtually come across to them and or whomever our audience is and say the only reason we're telling you this is because it's true and it's important and it can help you. Not, I'm on a secret sales mission funded by a company or by an insurer or whoever to change the drugs that you use or other practices that you're engaged in. And that really is an enormous strength of all of us. And it's what gets us access very often. Next slide, please, Bevan. Okay. So things have never been as 100% squeaky clean as any of us would like. But in the last months and years, things have gotten dramatically worse about this issue of provenance and what is true and what is not true. We've always known about industry-sponsored so-called CME courses that really are pitches for their drug, but they will have a hired gun from a local medical school and talk about how great this product is, and you've really got to look hard to see that the program was sponsored by the manufacturer of that product. Things have gotten better. There was a low point decades ago in which things were basically out of control, and there has been a bit, as all of you know, of a reformation in that there needs to be clear stipulation of who's paying for this. Conflicts of interest need to be spelled out better, and other things that have made this not quite as tacky as it used to be. The junkets that people could get paid to go on, often in the Bahamas, to learn about a new drug and call it education, have really been cut back. But, it's still there, and we all need to be vigilant about it, as I know you all are. And, we now have a $500 billion a year market for prescription drugs in the US. And that is just guaranteed to bring out some shady behavior, even in the best of times. Same thing about ghostwriting and pay-for-play journals, which I mentioned. Next one, please, Bevan. Okay, so I would ask, if I were Bevan, does anyone recognize what that is? And I guess, since I respect Bevan's running of meetings, if any of you want, you can put it into the chat. And there's another picture from our junket to London and Paris. And as you're thinking about what is that rock about, this is a replica of the Rosetta Stone, which, as you all know, was a breakthrough in communication in that it combined the same text from Egyptian hieroglyphs and Greek writing, and there was a third, which I should have looked up but don't, so that one could actually look at the hieroglyphs and then look at the Latin or the Greek and say, oh yeah, so that's what that symbol of a bird with a hat on its head seems to mean. And kind of that's what we do. We take biology and we try to then relate it to mechanisms of disease and therapy that, on a good day, will result in there being a drug created that takes advantage of that translation, that we can demonstrate actually helps patients. And so all of us are, in a sense, carrying around our own little medical Rosetta Stones on our backs when we go to talk to doctors or other prescribers or other audiences about the relation between biology and treatments and patient benefit. Next one, Bevan. So the good old days I now think of as before this year, where there was a lot of respect and emphasis on what was the study design when we think about communication, particularly public communication about meds, or frankly, FDA communication about meds. Were these randomized trials? Were they good observational studies? What was the effect size, the significance levels, the things that all of us on the call are likely to have pulled our hair out over the years. And then the journals, for their part, as we all know, will do their own reading of the evidence and say, well, we're not sure you've made the case, and the p-value is not less than 0.05. And my favorite sentence to get in a journal, often with a rejection letter, is, will this change the practice of medicine? Kind of a high bar that JAMA and Annals and New England Journal like to have. But, the not massaging, but the scrutiny of the work to get into a good journal, as we all know, is just enormous. You can't say something caused something else if it is an observational study. You can only say it was associated with. And FDA, again, until recently, did its best to look hard at all this evidence. Kesselheim and my colleagues over at the division have written about how they sometimes are not as careful about this as they might be, but they at least spend a lot of time and energy thinking about these things. Next one, Bevan. Okay, but we got a foretaste of this the last time Trump was president, where, as you all will remember, during the pandemic, he would get behind a podium at the White House and say that hydroxychloroquine is a good way to treat COVID, or bleach, or convalescent plasma, something he actually forced the FDA commissioner of the day to advocate, and it turns out it doesn't really work. And what was a remarkable drop in the standard of evidence was that there was no shame that he seemed to evidence about the fact that he had no understanding or training in these issues. One of his hench people came up with the concept of alternative facts. And in that first administration of his, we saw a new low in communication about medication risks and benefits. And I had kind of hoped that when we moved beyond that first term, we would go back to the kind of careful thinking that we're used to about health communication. But as we all know, there was another election, and we're in an even worse spot. Next one, please, Bevan. Okay, so now we are truly in a world, and again, I would not have said this a year ago. Well, maybe a year ago, because it would have been after the election, but maybe 13 months ago, I never would have said that we now are in a position where policy determines evidence instead of evidence shaping policy. And some examples that are just really pretty upsetting, but I want to draw your attention to because it is this kind of naked manifestation of politics masquerading as drug evidence. That mifepristone should not be used because to terminate a pregnancy because it is unsafe. Now, everybody has their right to believe what they want to believe about abortion, obviously. And if somebody opposes abortion, then fine, let them oppose abortion. I sure don't, but if they want to, okay. But I think doing it by virtue of saying that mifepristone is an unsafe drug is just doing violence to anything that we understand about drug safety and evidence and 20 years of experience. Or the fact that the man who is in charge of the entire US health apparatus, RFK Jr., who oversees, as you all know, Medicare, Medicaid, the NIH, the CDC, the FDA. All of them report up to the Secretary of Health and Human Services. And apparently he doesn't really believe in germs or that viruses cause disease. And we all know about his really grotesque lack of understanding about vaccines, which he has now over many years, but now from a very terrifying podium, has been able to communicate to the entire country. And it was mentioned yesterday that Canada is about to lose its status as being measles free, and there is concern that that could happen in the US in the coming months as well. And it's really wreaked havoc on evidence-based communication about many things beyond vaccines. Some of you may have come across a brand new approach that FDA is taking. They started out by calling it a commissioner's priority review. Now they're calling it a national something priority review, where they get to pluck out, they being the FDA, get to pluck out new drug applications and really speed them through the process and go from many months of careful yet efficient evaluation to just a period of weeks and then a big one-day meeting and poof, you got a drug approval, most likely. And the possibilities for that kind of abuse are really horrendous. Kesselheim had a piece with our trainee Thomas Wang and our colleague Dan Carpenter in the New England Journal about this a number of weeks ago. It's degrading the process of drug evaluation to a level that has been unthinkable in the past. And that, of course, is the substrate of information that we all work from. And of course, it is no secret that the whole issue of Tylenol causes autism. In fact, on Friday, there's going to be a very good symposium that's open via Zoom to anybody at the Harvard School of Public Health on the real data about autism and Tylenol, just to have some of the best people in the world studying this, one of whom is Krista Hoybrechts in our division of pharmacoepi, really say, what is the information? And of course, it's not what you heard from the podium at the White House. Vaccines again, and the whole issue of leucovorin is a way of treating autism, that you can have the president of the United States and senior health officials saying stuff like that would have been astonishing had we not heard it during the pandemic for other things. Next one, please. Okay, so in communicating at the moment about medical products, drugs or vaccines, all the norms that we've gotten used to of accuracy, evidence, provenance, nuance, and common sense that have worked so well are now pretty much being smashed at the highest levels of government, which makes our responsibility more important and our jobs much tougher. Next, please. Okay, so it's kind of like as I imagine being in an environment where there's a lot of polluted water and the food supply is contaminated with bacteria, so that it's even more precious to have a pure source of hydration and nutrition because the slop around you is just so toxic. So the question that comes up is, how much should we acknowledge that contamination, or do we just try to do the when they go low, we go high strategy that seems to have not worked so great for one particular party in government? Or do we just call it out and say, no, there's actual stuff that is not true, And as Senator Moynihan once said, we're all entitled to our own opinions, but we're not entitled to our own facts. And an issue that all of us will face in dealing with and shaping and administering programs is, to what extent do we take these issues on, or to what extent do we just say, no, we're going to go the Michelle Obama route and just be dignified purveyors of truth and not sink to the level of calling the lies out for what they are. Next one. Okay, so this really is an unprecedented time, and I've been around for quite a while, and I've never seen things this bad in terms of medical reality, medical evaluation, medical communication. Um, and part of that, of course, that we can never lose sight of is the wider picture of just access to healthcare. If a patient can't get to see a doctor or a nurse practitioner, they can't get a prescription. And if they don't have drug coverage, they can't probably pay for that prescription. So at the very same time that medical information is getting degraded, we also are having unprecedented numbers of people who are going to be losing their coverage, not just when the Medicaid cutbacks kick in after the midterm election, but even before that, as you all know, when the subsidies for Obamacare, about which we just had a long and apparently fruitless shutdown of the government, when those subsidies are canceled, as they will be on January 1st, people are going to not be able to get to the doctor or pay for their drugs. And so that's something we can't really forget about. So something I've been wrestling with is, what should we talk about, whether it is a clinician talking to a patient or an academic detailer talking to a doctor. To what extent do we say, well, here's a drug that doesn't work so good, but it's really cheap. So if your patient has to pay out of pocket when they're kicked off of Medicaid, maybe this will work better for them. I think we have to engage with those issues because we're not able really to avoid them. They are real. And again, we got to keep coming back to our core values of the best possible evidence that we will communicate accurately and effectively. And the effectively piece is one that I know we're all concerned with. It's not about sending out a memo. It's not about changing a formulary. It's about what all of you do and NARCAD has been talking about, and what we work so hard at ALOSA about, developing the materials, training people, whether they are at the beleaguered VA academic detailing service or in another context of care delivery. The training, the sending the people out, and the evaluating are all key parts of what we're all about. Next one, please. Okay, so huge ripoff in the making, which brings us to the present moment. So when we were in Paris celebrating my wife's good health, we were driving down the Rue Rivoli, and we passed this lovely museum. And I snapped a picture from the taxi, and I said, "Isn't this great that there are these gorgeous works of art behind these wonderful big windows, and anybody walking by can see them, and the lights are on all night, even after the museum's closed, and how wonderful that people work so hard to create these treasures, and now they're there for all to see." To which my wife, who is much more sensible than I am about a lot of things, immediately replied, "It doesn't look safe to me. Those are very big windows. Somebody could just smash those windows and steal that art. It's nice that everyone can look at it, but I think it's a security risk." A day and a half later, that jewelry heist occurred that we all have been hearing about for so long. And, she kind of saw it coming. She said, you can't have all this stuff behind big windows and not guard it appropriately, or it's not going to be there. So that I kind of think of, and there's sections in my book, Rethinking Medications, where I analogize medical discoveries to special works of art that have been created usually by groups of people and not a single artist, but over many years of effort. And they are these wonderful things that you can kind of hold and look at and marvel at. And yet, if you're not careful, they can be taken away. And for a lot of our patients, the jewels of the medical discoveries that we've not been so careful about protecting are indeed going to be taken away from them. Next slide, please, Bevan. Okay. That collection was hundreds of years in the making, much as our medical discoveries are hundreds of years in the making. And we just kind of, in Paris, lost track of their mission, in the sense that there was not enough security. They had cameras pointing the wrong way, which I can think of a dozen analogies with the way we protect or don't protect healthcare. Vulnerability was not in the forefront of their minds. and many patients who will lose access to these jewels of medical discovery in the coming year as their coverage is taken away. As at the Louvre, those jewels are not going to be available to them. And if they are discovered in 10 years, that will come too late, both for a lot of museum goers and for a lot of our patients. Next, please, Bevan. All right, to summarize before I give you another barrage of photos and try to end on a somewhat happier note, it really is that, we've all heard a million times that it's the best of times and the worst of times. And that was actually a sentence written by Victor Hugo in Paris in the 19th century when things were even more chaotic than they are now. That we are really living at this year through an acute crisis of polluted evidence, toxic communication, and cruel denial of access to care, without which, of course, you can't get any meds or any healthcare services. But in a way, in every important way, that makes what we are doing much more important now than it has been for a very long time. It's always been important, but now it's kind of emergency level important if we can find the funding for our programs, because as many of you know so well, and as we know at NaRCAD and ALOSA and many other programs, at the same time that the care is being taken away and the information is being rendered toxic in Washington, the support for a lot of our programs is also being taken away. But this too shall pass. 2 nights ago, Karen and I were at a dinner with a faculty colleague who's at the law school, and he pointed at a restaurant in Cambridge, kind of close to the university, and he pointed across the room and he said, "Oh, there's Steve Breyer, the former Supreme Court Justice." And I said, "Oh, do you ever get to talk to him at the law school?" He said, "Yeah, we talk all the time." And I said, "Is he very tragically upset about what's happened to the Supreme Court from which he stepped down a couple of years ago?" And he said, "No, he actually takes a long view. He does not think that everything is crashing and burning. He has a view of history that we have our periods of craziness, both on the Supreme Court and in Congress and in the presidency, and they come and they go. And I guess, you got to be as experienced and smart as a Stephen Breyer to see that about the Supreme Court. The other Harvard faculty member that I sometimes look to for this is Steven Pinker, who's in the psychology department, who's written books that often annoy me about how, if you really look at the whole sweep of human history, things are actually getting better and better, and you can't let these blips trouble you. But they're both smart guys, probably much smarter than I am, and I suppose something we can take hope in is that over the sweep of history, these bouts of craziness, this has not been the first, it won't be the last, but they do tend to go away and we end up righting the ship. There will be casualties, both for individual patients and for trainees and programs, but the hope is this is not, I don't think, guaranteed to be our steady state forevermore. Next one, Bevan, please. Okay, so the encouraging bit is this is the Bibliothèque Nationale in Paris, the National Library. And we visited there, and I thought it was going to be just kind of this kind of ancient, beautiful, but empty room. And it was jam-packed with students and citizens and just, regular folks all reading and looking at those wonderful collections and with their laptops as well. And it kind of gave me hope that, this building's been around for well over 100 or 200 years. And it's still being used, and people do still read stuff and benefit from it. And that, I think, was encouraging. The next couple also illustrate, to wrap up, sort of where I feel we're at the moment. Next one, Bevan. Okay. There's an amazing new museum, newish in the last number of years, that was funded by Louis Vuitton, but thankfully there's no fashions in it. Otherwise, I wouldn't have gone. But we often feel kind of like we're in one of these very modern structures, and there's people walking up the stairs and down the stairs in this kind of cold environment. It reminded me sort of a Max Escher print. And often we will feel like, am I going up the stairs? Am I going down the stairs? Who am I with? What am I doing? Next one, Bevan. Or to turn to a local market we went to right after that, we feel, as I often do, kind of like shrimps. Like we are just these little creatures swimming around and without a whole lot of control over where the currents are taking us, and certainly without a whole lot of power to change our fate. Next one. And we are at risk of being gobbled up by this strange new monster. This is the outside of the Vuitton Museum, which looks like it's about to consume whatever is in its path. And it's a feeling of great vulnerability that I, for one, have that was not made any better by going to this museum in the market. Next one, Bevan, please. Okay, this is a window on one of the main shopping streets in Paris. And I know that there are days when many of us wake up in the morning, and this is kind of how we feel about absolutely everything. And apparently, whoever owned this store in Paris felt the same way. Next. All right. And then to kind of bring this to a more happy conclusion, this, as you all know, is the Notre Dame Cathedral, which a number of years ago, five, I guess, six, almost burned totally down. The spire burned, and the art inside was largely, if not utterly destroyed, at least harmed and needed to be renovated. And it reminded me of something that I actually heard for the first time as a young boy in a religious service, and the rabbi was discussing a man walking along a road, and he sees somebody laying one brick on top of another, and he says to the guy, "What are you doing?" And the bricklayer says, "Can't you see? I'm laying bricks on each other." And then he goes a little bit further on, and he sees somebody doing the same thing, and he says, "And what are you doing, my friend?" And the person says, "Can't you see? I am building a tall wall." And then he goes on to the next person that he sees working on this, and he says, "What are you doing?" And the man says, "I'm building a cathedral."
Mm.
And in a lot of ways, that's kind of, we can either see ourselves as laying one brick on top of another, or just building a wall, or that we are all engaged together in building some large structure that will be there, hopefully, for many, many years to come, and will serve a purpose that is not just about building a wall. Next one, please, Bevan. Okay, and this is Saint-Chapelle, which is what happens when you build a gorgeous structure. The light comes in, it gets reflected and refracted by these gorgeous windows that are there. Again, something that stands for hundreds of years, and at a time when some of the things we value the most seem to be getting torn down, it helps to be able to look at things that people did 100, 200 years ago that are still there and beautiful and can really inspire us in the work that we're doing going forward. Next. And finally, as we all try to build bridges, how to work that in somehow, between the best possible evidence and the best possible care of patients, it's a journey that we're all on together, and hopefully we can get across the river together and things will be somewhat less deranged in the years to come. Okay, I think the last slide is going to be just some follow-up. We got to keep following up with each other and I think the community that Bevan and Mike have built around NARCAD has been such a source of comfort, particularly in these awful times. Remembering what our values are, which is, evidence and communicating things sanely and effectively and interactively. I've taken to LinkedIn because I've gotten frustrated with how many months to years it takes to either write books or get things in journals. So if any of you want to check me out on LinkedIn, you can do so. I might be doing a Substack in relation to I haven't yet, but in relation to communication, which I think is very relevant to what we're all talking about at this conference. Within 1 2-day period, a week or so ago, kind of unrelated to one another, both Zeke Emanuel and former FDA Commissioner Rob Califf said in utterly different circumstances that they are taking to TikTok, Instagram, Substack, and any number of other media because they feel like they've got a lot they want to communicate and that it just doesn't work to only do books and journal articles and treatises, because their goal is to meet people where they're at, and they want to make sure that they are not off on a high horse that no one's going to really be taking too much notice of. And I just wanted to pass the strikingness of these two very senior people in the world of medications and healthcare, both independently. We're talking in different contexts about that need, which is why I'm more on LinkedIn than I used to be, and maybe needing to start a Substack. But something you will see on LinkedIn as of this morning, not on my post yet, because I have been getting ready for this talk, But there's a great podcast called Health and Veritas, run by Harlan Krumholtz at Yale Medical School. And Harlan is, of course, a major leader in medicine. And yesterday we recorded a podcast about my book, and it's up this morning. Again, a little quicker turnaround than you get with the New England Journal. And I think they've been posting on about the Health and Veritas podcast episode that I'm on. And if you come across it, or you can just go to any podcast purveyor and see it, we had actually ended up talking mostly about academic detailing. As it turns out, that's what they wanted to discuss, and it should be easy to access. And again, as we all think about how do we communicate, writing things down and submitting them for publication is not the only way to do it. And this thing that we recorded yesterday, it's up there today, and people will be able to access it forever, is a very appealing mode. And I think all of us, as we think about next year's conference, may want to have a session on social media and academic detailing. I know that many of your programs are already active there. And certainly NaRCAD under Bevan has done a great job being prominent on social media. And I know that ALOSA is much better than we were with our new website that Dr. McNagny has taken such a good role in making happen. And, what are the other media besides only writing things down and then going in and talking to somebody directly? And I cannot help but mention the book, Rethinking Medications. It just came out this year by with Simon and Schuster. The website is rethinkmeds.info, and there's a whole chapter in it on academic detailing and a lot of other chapters on where does evidence come from and how do we manage to make sure everyone has health care. And so I think pretty much everybody in this conference, as well as pretty much everybody will enjoy reading a copy. And that is the cover of it that Bevan has put up there. And I think I've ended mostly on time for questions. Yep, 11:52, Bevan. That's what you told me.
I don't know how
Okay.
you did that. That was amazing.
All right, great. And so that gives us 8 minutes for conversation. Is that your plan?
It certainly does. And I am just very excited by all of the chat as well, especially Charles in Maine says that he is very concerned to learn that you were in Paris when the jewels went missing. So we'll have to talk about
Well,
that.
even more so that my wife saw it coming a day and a half earlier than it happened. So, we were hoping that the cab driver did not speak English because he would have gone to the gendarmes and said, I think I know who planned this.
Wonderful. Thank you so much, Jerry. And every article, podcast, LinkedIn you mentioned are all in the chat, and you will all receive those links via email. But thank you, Jerry, for your wonderful talk. And please start putting questions in the chat box for Jerry. These are your minutes. This is your time to speak with him. Mike, I know you have a reflection as you often do. So why don't we start with you, and that'll give folks time to pop some thoughts in the chat, including Jerry, that someone just mentioned that they just placed a hold for your new book on the audiobook version, which you yourself read. Is that correct?
Right. It is read by me. So it's like having me on your jog or in your bed as you fall asleep. Yes.
Wonderful. Wonderful. Mike, over to you.
All right, Jerry, thank you. That was wonderful, as always. I'm curious, we exchanged a couple of emails about this around when your blog post went up. We at NaRCAD focus on the US situation because it's where we're based, and frankly, some of the most dramatically terrible things have been happening here. But you and I both mentioned the Canada measles situation in our talk. There's a lot of international misinformation, and I'm curious how you think about international collaboration. You have a history with that. Since I didn't have time to read your whole CV because people can't stay until next Monday, you were the president of the International Society of Pharmacoepi at some point a bunch of years ago, and so on. So how do you think about sort of international groups coming together, whether it's across academics, across public health, as part of the response to this?
Great question. And I think that there's good news and bad news. I hope more good news than bad news. The good news is that
82 participants.
Oh, we're going to mute anyone who's not Jerry. Back to you, Jerry.
Okay. The good news is that it is always invigorating for me, whether it was in the International Society for Pharmacoepi or NaRCAD and our wonderful international collaborators from Australia and Japan and Norway and Canada. to see all the great stuff that is being done there. And even if we are, as a nation, heading for a little bit of a deep freeze, hopefully not forever, that the work goes on. And that's very invigorating and inspiring and reassuring. The little bit of bad news to throw out is that if anybody had asked me 13 months ago, would we be in an environment in which just ridiculous lies about what works and what is safe in the world of medications would be made at the highest levels of government, and that the FDA would have had kind of a nervous breakdown, and that the CDC would be more or less castrated, I would not have thought that any of that was imaginable. And so what I mention that because clearly there are struggles in every nation in the world about Trump-like forces wanting to take over the government. Thus far, it's happened very solidly, primarily here and maybe, in Hungary and in Russia, and maybe China. But most of the rest of the world is still safe. But any of you who don't live in the US, don't get too cocky, because, it can happen anywhere. So we need to be vigilant about even the early signs of that in other countries.
Mm. Thank you for that, Jerry. Aaron from Canada says, one thing we always do in upskilling is look at multiple countries' guidelines, not just our own, both for recommendations and for important references, and looking for discrepancies. So very key to follow up on that. Folks, we have time for another question, another reflection. Trish has a question. What's the number one thing you'd recommend all academic detailers or programs do to focus on moving forward and rebuilding to keep that historical long game perspective?
Great question. And I wish I had an easy, quick answer, which I don't. But I think just hanging in there and understanding that what we do is so important and so valuable that even though there may be a period where it is kind of out of fashion politically and economically, it is so valid and useful that I'm sure if we can just hang in there during this hiatus period, the country and the world will once again come to value it. And the analogy that I talk to the residents and students about that I work with is thinking about how there was all this wonderful Greek culture that developed during the classical era. And then the Dark Ages set in across Europe, and people did not read Plato or Homer or Socrates or Aristophanes. And, they're mostly, from what I can tell, going around hitting each other on the head with truncheons. And that lasted for a couple of hundred years. But during that time, the Arab world continued to study and cherish the classical writings, and monks in monasteries continued to copy over, since that was before we had printing, the Greek classics so that they would be preserved and studying them. And while I am neither a monk nor an Arab, I think that's an example that really we can cherish, that hopefully we're not looking at a couple of hundred years of Dark Ages. But as we know, the Renaissance followed and people rediscovered all those great classics that the Arab world and the monks in the monasteries had preserved and made great use of it and carried things forward. So we're kind of like the monks and the Arabs during the Dark Ages. And if we can just manage to find the funding to kind of meet payroll, things are probably going to get better, maybe even as soon as November of next year.
All right, we are officially back and up and running and recording this second half of day 2. We have 2 main sessions left. We're excited for both of them. So get yourself settled after your break and your breakout sessions. Really excited to hear from you what you learned. And what we have up next is a really exciting grouping of presentations that we have called the Think Tank: Communicating Credible Evidence, Best Practices in Curation, Delivery, and Evaluation. So looking at 3 major components, not all of the components, but 3 major components of building and delivering and assessing an academic detailing program. So glad you're all here. You're really in for a treat. But of course, we have a chat waterfall question for you just to get a sense of what you think the most difficult part of an AD program is of these three. So is it C, curating the evidence, D, disseminating the evidence, or is it E, evaluating the impact? So pop on over to your chat and decide what you think is trickiest. I knew we were going to get a lot of E's. Look at all those E's. A lot of E's, couple D's. Yep. Yep. Evaluation is tough. Not to minimize our two friends up in Maine who are saying it's tough to disseminate. Also true. But boy, there's a lot of E's. Okay. Well, Victoria from Chicago is going to have her work cut out for her, as she will be doing part E. But everyone will have really fantastic skills to share, and hopefully translatable nuggets regardless of the size of your program, the scope of your program, the resources you have. And yes, C has gotten tougher. We did learn about that this morning and yesterday by some other guy. So up next, we have our first of these three presentations, and I'm excited to turn it to our director, Mike, to introduce these two fantastic women who are such integral parts of our community. Over to you, Mike.
Thanks, Bevan. And yeah, this is really excited about this think tank session. I think this group of presenters is going to pick up on some of the concepts we've been talking about over the first, over yesterday, over the first half today. This first presentation in particular on some of the themes and topics that Jerry brought up so compellingly this morning. So first up in this duo for this presentation is one of our close NaRCAD friends and allies, one of our most popular training facilitators. She's been doing that for, I think, maybe 6, maybe almost 7 years now. Jackie Travers, who's a clinical pharmacist. She's organizationally with Pharmacy Management Consultants, which is part of the University of Oklahoma College of Pharmacy. She's led their academic detailing program for 10 years now. And she focuses primarily on Oklahoma Medicaid providers with a real focus on pediatric issues, some of the most vulnerable populations in the state. Jackie, we always look to Jackie as epitomizing the determination that it takes to make a small program thrive and survive, something that provides a lot of lessons for all of us. She really has worn every hat, developing materials, delivering services, analyzing programs, all of it. Jackie's joined by her colleague, Yahara Valdez, who's a public health specialist working with the Oklahoma State Department of Health. She's focused on diabetes and cardiovascular health improvement across the state. She also works with the University of Oklahoma College of Pharmacy with a particular focus on health equity. I really wanted to call out, I think it's wonderful. Yahara is a certified medical interpreter, so another example of the multidisciplinary community that we can draw on for our larger NaRCAD universe. And she's got a real passion for serving the Hispanic community in Oklahoma. So Jackie and Yahara will be sharing with us on an absolutely wonderful title for their topic, Tending Our Public Health Garden, Keeping Out the Political Weeds, and Finding the Evidence-Based Fruit.
Thank you so much for that lovely, lovely, lovely introduction. We're just thrilled to be here, and welcome to all of you. Good morning, good evening, good night, whatever your time zone. As you heard, I am Jackie Travers, and my amazing colleague Yahida and we're going to get you back to basics today. We're going to kick it old school and share some practical ways that we can, as Mike said, stay out of the political weeds and find our evidence-based fruit. Next, please.
So to start off, the last few years, especially during COVID, really showed us how important it is to have reliable evidence-based information. At the same time, we were surrounded by a lot of misinformation, and a lot of politics were mixed into the health recommendations. So during the pandemic, guidance was coming from all kinds of places. And honestly, it often shifted depending on political agendas instead of sticking really and truly strictly to the science. So that made things confusing, not just for the public, but also for those of us working in the healthcare field and as public health professionals. So we also saw research being published faster than ever, and they were accelerated timelines, more open access platforms popping up. We saw, of course, the whole publish or perish culture that pushes out a ton of studies really, really quickly. So it's no surprise that many healthcare professionals feel flooded with information, maybe overwhelmed, and not all of it is high quality. So that's really the point of today's presentation on how we stay focused on real evidence and avoid getting pulled into the political weeds. Next slide. Thank you. So to come up with the overwhelming amount of information out there, a lot of providers turn to free open access medical education, better known as FOAM. And FOAM shows up on all the platforms you see here: podcasts, blogs, vlogs, social media, and many different medical educational websites. A quick fun fact about the name, the term FOAM, it actually started in 2012 at the International Conference on Emergency Medicine in Dublin. And so the story goes that Dr. Mike Cottigan and a group of like-minded physicians were sitting around having a conversation over a few pints of Guinness. They wanted a new term to describe the growing world of online medical education, but they also wanted to separate it from the idea of social media and everything going on right now. So since that phrase had some negative associations, the term foam literally bubbled up over a pint of Guinness. And so at its core, foam is really just a collection of free, open access medical education resources. And the idea isn't to replace things like textbooks or journal articles or formal lectures. It's meant more to supplement them. So it gives us and providers, public health professionals, everybody a fast, accessible way to stay updated, especially when everything is changing very, very quickly. So that brings us to our first chat waterfall. Which foam resources do you guys use most often? And if you have the actual name at your fingertips, that's even better. Podcast. Yep. Definitely lots of podcasts.
Why do you think that is? Yeah, Haida, like that podcasts are such a big
I think the easy access to it, somebody can put it on while they're at work, while they're driving. I mean, there's very many ways to access a podcast easy and effectively in different formats. So it's more than likely the podcast is the easiest way to go. I know I will sometimes turn on a podcast, while we're working just for the background and we're learning as we're going. So definitely the easiest route to do is to do a podcast.
And we have a comment too that rural detailers drive so much that podcasts are their friend. So
yep, exactly.
Yep. We also have open evidence, superb for MDs, Substacks, webinars from my state SUD learning community, a few more for websites and carefully curated podcasts, and of course, ALOSA, LibGuides, etc. And it also depends on learning styles. Great point from Michelle. Back to you, Yahida.
Great. All right. So as we talked about on the last slide, blogs are a huge part of foam resources. Now we're going to take a look at a 2024 study that analyzed emergency and critical care medicine blogs. They reviewed more than 2,000 posts. And interestingly enough, just 6 sites made up over half of all those posts. So you can see them listed here along with the number of posts each one published. And here's what the study found about these top foam websites. About 90% of the authors were academic, which you might expect, but almost 80% of them didn't include a conflict of interest statement. About 70% of the authors had MD degrees, 60% were men, and more than 90% of the authors lived in the US, Canada, or the UK. So in some cases, there weren't even authors listed at all. So it's not always clear who the content creators are behind the information we're seeing. So no chat waterfall here for this one, but think about the last foam resource you accessed. What do you remember about the authors, host, or the guests in particular? Next slide.
All right, so it might be starting to sound a little bit like we're maybe not a fan of foam, because you heard some of the downsides, conflict of interest, and authorship sometimes not being present. But no, it's not that at all. It's just that we want to make sure that's not where we stop gathering our information. We want to make sure that we're spending our online currency on the highest quality of evidence. So the take home here is use foam to learn quickly, but use the hierarchy of evidence to decide wisely. And so now you may have seen this pyramid before or a very similar one. At the bottom of the pyramid, we see the lowest level of evidence, and at the peak is the highest level of evidence. So we're going to look at each of these types, starting with the strongest. That being systematic reviews. They are our bread and butter, okay? Systematic reviews, bread and butter. Authors will look at all the published studies on a topic, and then those studies are synthesized or condensed into the best representation of the strongest studies. Lots of times you're going to see results presented using a meta-analysis. And so you will sometimes see these two terms combined or even used interchangeably, but they're actually different. And so broadly speaking, meta-analyses combine the numerical results of several trials to generate an average number of the result that we could reasonably expect to see. Okay. Systematic reviews are more than just a narrative review that seeks to only describe the previously published works on a topic. But in a systematic review, the quality of the evidence is gathered for each of the outcomes across multiple studies. Very often you're going to see those evaluated using the GRADE system, which stands for Grading of Recommendations, Assessment, Development, and Evaluation. And so when we use the GRADE system, we find that the studies are downgraded for risk of bias, inconsistency, indirectness, imprecision, and they can also be upgraded for a dose response effect or a large effect that a particular study saw. So it's kind of weighted. You could kind of think of it that way. Very often, systematic reviews are done or even requested by certain groups, colleges, academies, things like that, in order to create a clinical guideline. So take home here, we want to be primarily using systematic reviews when deciding which evidence to recommend and implement at the public health level, for sure. Next slide, please. Great. Now we have randomized controlled trials. Lots of times you hear those referred to as the gold standard, primarily because these types of studies, the RCTs, will establish causation, not just association. A lot of the other studies that you're going to hear us talk about only can establish association. So in a randomized control trial, we have a comparison, often with the placebo, or dare to dream the actual standards of care that are existing in the big wide world. And so participants are enrolled in a treatment arm, comparison arm, and then the results are analyzed. Patients may be blinded, participants may be blinded, evaluators may be blinded, not necessarily a requirement, but it's pretty common. And again, this is the best study to evaluate causation. Next slide, please. Now we have cohort studies, and these will look at a specific patient population where a smaller subset of individuals has experienced a particular exposure. And often they're going to compare the rates of disease development in exposed versus unexposed individuals over time. And again, you're going to hear me say this many times. This study does not show causation. It's an association. So if you see a study that, oh, sorry, my battery's beeping. Bear with me real quick.
Hang in there.
Yep. So there we go. If you see a study that looks at a group of people who have a disease or disorder now, and someone tries to say they have looked back into individual medication histories, and they find that the patient or maybe their mother took a certain drug, we can't say that this drug caused the disease or the disorder. That's just not how cohort studies work. This is why we can't have nice things. Okay, next slide, please. Sorry. Okay, cross-sectional studies. So just below cohort studies in their strength of evidence is the cross-sectional studies. And so it's an observational study that involves collecting data from a population at a single point in time to examine the prevalence or outcomes or to explore associations between variables. So we could actually conduct a really quick and dirty cross-sectional study right now. So that's what we're going to do. So no chat waterfall here, but let's do a quick show of emojis. Who here has had at least one cup of coffee today? I'm going to zoom out so I can see everybody. And Bevan, maybe you can help me see.
Yeah, let's see. I'm going to type caffeine in the chat and you can thumbs it up.
Yes. All right.
I see a smile. I see sunglasses. I see lots of love. I see eyes filled with hearts. So I know there's more than just this. Sure. Mike has had
So-
3.
Great, that's great. So you all just participated in a very simple impromptu cross-sectional study. We have established the association between attending an international conference on academic detailing and coffee consumption. So sorry, I did not get permissions and disclosures, and this did not go through our IRB, but
You blew it.
all right. Next slide, please. We have the case control studies. So in this situation, we have 2 existing groups with or without a disease, usually, and they're compared to identify disease risk factors. So this type of study, it's quick, it's economical. There's no need to wait for the disease to develop. Makes it really good for studying rare diseases. And case control studies can often serve to present initial findings that can then be tested using more rigorous research methods. One of the first studies showing a link between smoking and lung cancer appeared in 1950 as a case control study. Multiple other studies followed, as they should, but the case control study was the first step. The case control says, hey, maybe we should look over here. There might be something to pay attention to. Next slide, please. Now we have the case reports and case series, and these describe a clinical event like a diagnosis or a treatment, typically involve a really low number of folks, as you can see there. Case reports, typically 4 or fewer. Case series, typically more than 4. Like cohort studies, they're also helpful for identifying rare diseases, unusual presentations. Also don't show cause, okay? Again, just want to drive that home. It's particularly ill-advised to draw a cause conclusion here because there's not really even a comparator, okay? There's no comparison in this case, but they are really helpful in generating hypotheses for subsequent studies. So in 1981, we have probably the most famous case series to date. Doctors at UCLA reported that they saw 5 patients with pneumocystis pneumonia, a rare form of pneumonia that had appeared in these previously healthy young men. And as we now know, these 5 patients had been exposed to the HIV virus. They had developed AIDS. Thankfully, now we've had thousands of additional studies on HIV and AIDS. There have been randomized controlled trials that have resulted in approvals of life-saving medications. And now we're able to largely treat HIV as a chronic disease and avoid transmission entirely when evidence-based steps are followed. But that first little piece, that was a case series there. Next slide, please. Yes, great. So last, and in this case, actually least, we have basic science, translational research, and expert opinions. It's not that these are without value, it's just that they should never be used alone as the basis of making a clinical recommendation, let alone a public health policy. Basic science is the laboratory studies that provide the foundation for clinical research. Think mouse models and petri dishes. And as the name implies, translational research translates basic science into clinical science. The development of the mRNA vaccine technology is an example of translational research. It was research that made the COVID vaccine possible. Publications that focus on basic science and translational research are literally foundational in terms of evidence, and they absolutely are needed to help drive the formulation of hypotheses and to make sure that everything's safe to then test in humans. And then at the very bottom, along with these, we have expert opinions. Now, we're not using air quotes here, okay? We're really, truly talking about experts in the field. But of course, someone who is not an expert in the field does not even appear in our hierarchy of evidence. So we don't need to concern ourselves with their opinions at all when making a decision about the most evidence-based pathway to get to a clinical decision. Even when the opinions are from true experts, though, we're still at the bottom of the evidence because the opinion comes out of personal experience, which is the least reliable source. Experts are knowledgeable, but their opinions are still just opinions, subjective, biased, and lacking the rigor of a data-driven method like a systematic review.
All
So
right.
we have our next chat waterfall. All right, so thinking about the last public health recommendation or proclamation that you saw, heard, read, where does it fit? High, low, what type of evidence was it? A specific category? Not even on here.
Yeah, that's me.
Yep.
Exactly.
Yep.
Yeah, not even basic science.
Yep.
Non-expert opinion, Carrie says same, not even on here, no evidence. Right, because the ones that are the most out there do stand out in our memories, I'm sure. What else? Anyone else have similar thoughts? We've got agree, ignoring randomized control trials and paying attention to case controls instead, says Aaron. Anyone else have anything different? Mike says agree, even if expert opinion is problematic, then expert opinion, using the word expert, is really dangerous. That really begs the question of what are we even using as the rubric to identify an expert. Okay, back to you, Jackie.
And I'm going to kick it to you, Ida.
Next slide. All right, so now that you know where to go when you quick high level look at a topic, you have a sense of which types of studies you might want to pull. You're ready for the next step. So actually forming a clinical question. So the big question becomes, what do you need to know? What kind of answers are you hoping to find? And that's where the PICOT framework comes in. So PICOT stands for Patient Intervention, Comparison, Outcome, and Time. The PICOT gives us a structured way to build a solid evidence-based question, and is used all the time in healthcare and clinical research because it truly helps us guide our search and makes it easier to appraise real scientific evidence in a systematic manner. So it also helps us figure out which studies are most valid, most reliable, and ultimately the most applicable when we're trying to make an informed decision in practice. Next slide. Thank you. So now we're going to take a closer look at each part of the PICOT acronym. So starting with P, that stands for patient, but it can also refer to a whole population or a specific problem that the patient or population has. So for our purposes, it all means pretty much the same thing. What do we want to learn about? So for example, premenopausal woman looking to start hormone replacement therapy, adults with hypertension, or even children with exercise-induced asthma. So each of these defines the population that helps make sure that the evidence we gather is actually really relevant to the people we're serving. So next we have I, which is the intervention. That is a specific treatment, exposure, or therapeutic approach that you're going to be focusing on. It could be a medication, a dosage form, a behavioral strategy, or anything you want to truly evaluate. Then we have C, comparison. This could be another drug, a placebo, the standard of care, or even an intervention, or even no intervention at all. So added a comparison that makes the clinical question stronger because it really puts the intervention into a real world context and kind of the situation we have going on. So for the O, we have outcome. This keeps the question centered on meaningful results like therapeutic effectiveness, fewer side effects, better adherence, improved quality of life, or even cost savings, especially right now in times. And then finally, we have the T. So for time, which is optional, sometimes time matters a lot. And sometimes it doesn't. For example, if you're looking for a yes or no outcome, like did an allergic reaction occur, you might not need a time frame. But if you're evaluating things like chemotherapy cycles or the duration of a treatment, then time becomes really important in these specific scenarios. Next slide. So earlier we started using the PICOT framework, helps us pick out the most valid and reliable studies. So let's take a quick minute to remind ourselves what those terms actually mean. When we talk about reliability, we're talking about consistency. Whether the instrument that we are using gives us the same measurement each time. And when we say validity, we're talking about the accuracy we are measuring when we think, or what we think we're measuring. So I'll go ahead and point out a typo on the slide. We do apologize. The second image should say poor reliability and good validity, not good reliability. So just keep that in mind as we walk through the examples. And for the first target image here, we think about a thermometer. As long as it's working correctly and doesn't need new batteries, it should give the same temperature every time. That's reliability. And because it's actually measuring the temperature accurately, that's validity as well. So for the second target, imagine a malfunctioning bathroom scale. Let's say you really weigh 80 kilograms, but you step on the scale 3 times within 1 minute. The first time you get 71, the second you get 92, and the third you get 83. Those readings are all over the place, so that's poor reliability, but the scale is designed to measure the weight. So over many trials, it would still average out close to about 80 kilograms, which means it has a validity in its purpose. So in the last image, we have a good reliability but poor validity. Each result is consistent, but they're consistently wrong. So think of something like using hair color to screen for clinical depression. Sure, hair color can be categorized pretty consistently into blonde, brunette, red, but hair color has absolutely nothing or no relationship to depression. So it's reliable, but it's not valid. Next slide. All right, this brings us to our last topic, the impact factor. The impact factor, or if, is basically a measure of how often articles in a particular journal are being cited. So it reflects the average overall number of citations to recent articles that journals have published. A lot of people use it as a quick indicator of a journal influence, prestige, or the overall scientific impact. But impact factor is calculated by the Clarivate Analytics, and they use data from the Web of Science database to do that. So just to clarify, impact factor only counts what they call citable items. They usually include original research articles and review papers, but things like editorials, letters, or news pieces don't count towards it. So when you hear someone say, oh, the journal has a big or high impact factor, they're essentially saying that the articles from the journal are being cited frequently, which can suggest to us that the journal is being well recognized or widely used in its field. Next slide. Thank you. So we talk about using the impact factor to help you decide whether to act or not act on a study's findings. It has some advantages, but like anything, it also has limitations as well. On the advantage side, we have impact factor that gives us a standardized quantitative way to compare journals, and it reflects how often a journal's articles are being used and cited by other researchers, which can tell us something about how influential that just specific journal or field is. But it also comes with some drawbacks. For one, the impact factor varies a lot by discipline. Some fields naturally have higher citation rates, cardiology, for example, while others may not. So comparing across fields doesn't always make sense. Another limitation is that the IF or the IF can be skewed by just a few highly cited papers. A journal might only publish a handful of the articles each quarter. But if one or two of those papers go viral in the research world, their impact factor will shoot up and rocket, even though the rest of the journal might not be as strong. It also doesn't tell us anything about the quality of a specific article or a specific author. So a journal can have a high impact factor and still publish a weaker article, and the opposite is true as well. So yes, while the if can be manipulated, excessive self-citation is a big one. So if you ever notice a study where the authors are spending half of the reference list citing themselves, that's a big red flag. There are some alternatives and complements to impact factors like the 5-year impact factor, the H index, the journal rank, and altmetrics, which looks more of online attention and engagement, and those can give you a fuller or better picture, overall picture of when you're trying to evaluate a journal. Next slide. So to wrap things up, here's a little activity you can try at home just for fun, and honestly, it can be pretty eye-opening. So using your updated evidence appraisal skills, try searching the term, and then I'll spell it out for you, the IVERMECTIN, across these different sources and compare what pops up first. So you're gonna see that look at how many hits you get, what kind of information is highlighted, how the tone or the depth changes depending on the site. Then think about how you might use those differences when you're caring for patients or making a decision in the real world practice. But for now, here's our last chat waterfall. When you're evaluating clinical information, whether from a foam source or a journal, what single word or short phrase now comes to your mind as most important for ensuring that the evidence you're using is trustworthy?
All right, let's see. What would you add to a search if you were Googling some clinical information to make sure the evidence you're using is trustworthy? What word would you throw in to your search? Systematic review. That's great, Aaron. Peer reviewed. We have validated. What else? Let's get a couple more before we transition. Any other thoughts? What do you think about these, Yahaira? Oh, there you go.
Sorry, I was muted. Those are great. Yeah, thank you for your responses, everybody. And we can go to the next slide.
Yeah.
All right, so these are the references we use along with a few extra resources if you'd like to explore more. Next slide.
And I'll make sure that all of these resources are also listed on the post-conference email list for everyone.
Great. We want to specifically highlight this last resource here you see on this page. If you want to go into things like confidence intervals, p-values, and such. And then next slide. Thank you. We're happy to answer any of your questions.
Thank you so much. What a rich presentation. I'm sure people are going to want to review the video again, have access to the slides, which you all will. We do need to transition to our next piece of the think tank, which is delivery. But what I recommend is if there are questions for Yahaira and Jackie, please put them in the chat and they will be happy to answer them via chat. Thank you both so much. We have a quick chat waterfall question. If cost and training were not an issue, how would you like to see tools and technology support AD campaigns? Another way to look at it is, what tool or tech do you wish you had? While you're thinking about that, I'm going to turn it to Mike to introduce Nilaksha Okade from Kaiser Permanente.
Fantastic. Yes, people can keep thinking about all the tools they would like to have. If you can't have Jackie and Yahaira follow you around to give you advice, as tempting as that would be. So keeping, continuing our way west from Oklahoma, we're back to California, where we spent some time yesterday. That's where Kaiser Permanente has had a long-standing AD program, actually connections to our team from far before NaRCAD was founded. Some of the early leaders in their program engaged with Jerry about creating their AD program back after the first papers were published. So it's wonderful to be able to maintain that connection over all these years. We're fortunate to be joined by one of their current leaders, as Bevan said, Dr. Nilaksha Okade. She's currently the medical director for pharmacy in Northern California for the Permanente Medical Group. She works with physicians and pharmacy teams across their system. It's, as people probably know, it's a big integrated system. And she thinks about strategic initiatives and clinical guidelines, policy development, how they deal with utilization, research, really the full range. She also leads their Emerging Therapeutic Strategy program, which is part of their national programming. And that's thinking about how they really work on innovative treatments organization-wide. She remains a practicing physician. She's board certified in internal medicine and in hospice and palliative care. And she'll be sharing with us today about leveraging tools, technology, and team-based care, the principles of AD implementation. Over to you. Thank you for joining us.
Thank you. Can you all hear me?
Yes, you sound
Perfect.
great.
All right. Thank you for that humbling introduction. I'm privileged to be here. And for the sake of time, I'll jump on to my presentation. I have no conflicts of interest to disclose. All right. So our integrated model, I mean, I know a lot of y'all are from the East Coast, may not be very familiar with Kaiser, so I'll give a brief introduction. Really, our integrated model is a comprehensive system that combines its health plan, the medical groups that are independent, and the hospitals into a single coordinated entity that we call Kaiser Permanente. We provide care just in Northern California to about 4.5 million members. And our medical group is called the Permanente Medical Group. As the health plan, the medical group, and the hospitals work together, they really share a deep and ongoing commitment to eliminate barriers and collaborate very effectively and simplify the access to services and care. So this, this structural as well as functional integration really benefits our members as well as communities. Our clinicians can very easily coordinate with each other and seamlessly refer patients to each other in terms of teams or specialists. Our primary care doctors, specialists. I mean, I can just Teams message a lab technician or a phlebotomist right on the spot, which is really a privilege when you're practicing in the world today. And then, of course, our robust electronic medical record really facilitates this coordination very effectively. Let's go to the next slide. All right, so value-based care, it's a hot topic, an emerging term, but really this has been the foundation of our industry-leading model for nearly 80 years now, and we continue to sort of build on it. Our care is definitely clinician-led. Our physicians work with their patients to develop very personalized treatment plans, making decisions about medical care together. And I think the important piece to highlight over here is that we do not have prior authorization requirements in our practice in Northern California. So physicians actually have the autonomy and privilege to prescribe as they feel is clinically appropriate. But at the same time, we do empower them to focus on evidence, quality, and safety. And then after all these boxes are checked off, cost effectiveness. Our physicians are entirely free of conflict, and we really take a lot of care and pride in ensuring that our formulary, our preferred therapies, our practice recommendations are very evidence-based, are written by clinicians, and are free of conflict. And then our purchasing, our contracting is also driven by that evidence-based decision that a physician and pharmacist makes. There are no hidden fees, and then the savings actually return to the health plan. There's no middleman. So, it is really as integrated as it can get. And in the next few slides, what I'm going to do is describe to you how we practice this evidence-based medicine via academic detailing. You're going to hear the words evidence, quality, safety, value a bit too many times in the next 10 minutes. But and I apologize for the repetition, but really that is our secret sauce, and I want to make sure that I sort of showcase that to you. Let's go to the next slide. All right, so one of the biggest highlights of our integrated system is really our physician-pharmacy partnership, and it's really our secret. It's our secret to our high quality, efficient, and equitable patient care that we do. We do this with a commitment, again, to quality and safety, and a commitment to thorough drug evaluations to ensure value. And our integrated system then allows us to use all of this to deliver the care efficiently. So in the next few slides, I'm going to sort of detail out, how we do it. Let's go to the, let's go to the previous slide. Maybe we missed a slide there. Yeah, okay. So, like I said, pharmacy is a big and critical piece of our integrated model. It's a very robust structure, very well-rounded, and a critical piece. I mean, if you just look at the parts of this wheel, right, we keep the patient at the center. It really allows us to be grounded in our mission. And then, we have our outpatient and inpatient pharmacies, our home health pharmacies, our infusion pharmacies, a specialty pharmacy, benefits, contracting, supply chain. We have a very, very robust pharmacist outcome research group. We have pharmacy informatics. And then we have a special group of pharmacists who have expertise and collaborate with our our electronic medical record, so as to input, what we need for our clinicians to use. And then I also want to especially call out our clinical pharmacy programs. It is one of the largest in the nation, and they are really integral practice partners to our physicians. And then under each of these groups, we have very many smaller groups and departments keeping this wheel very well oiled and running smoothly. There's, of course, interdependencies with more than what this slide can display, not just within pharmacy, but within our other care delivery groups too. But pharmacy really is a big piece when it comes to academic detailing. Let's go to the next slide now. All right, so this is a simple illustration, but each of these cycles can take like a year, 18 months sometimes. This really is a diagram of how we think about a drug use management initiative and how we put it through implementation. Again, it cannot be done without physician and pharmacy collaboration. Once there is an idea, a proposal for a drug use management initiative, we will start with our drug intelligence and strategy department of pharmacies, expert pharmacists who will review evidence and then make recommendations for the design. Really, we center on evidence. So these recommendations, the initiative itself is then presented to our physician stakeholders. It may be a preferred drug, it may be a preferred practice recommendation. It's presented to our physician stakeholders and our subject matter experts, our physician leaders, to whom that particular initiative may be relevant. So if it's a cardiology drug initiative, then, we present it to the cardiologist experts. After a robust discussion and multiple rounds of edits, they then, they endorse them, and then we take them actually to our pharmacy and therapeutics committee, for an official endorsement. At that point, then we start preparing to implement. And, we have 18 medical centers throughout Northern California, with local leaders and local stakeholders. And so then we start to begin creating educational materials and tools for our busy frontline physicians and pharmacists, and then other staff who may be integral to implementation. Then we have to make updates to our electronic medical record. We have to implement inventory strategies, make sure that our pharmacy contracting, our supply chain, our stocking is aligned with that initiative. So if we have a preferred biosimilar, for example, we have to make sure that we have the ability to dispense the right drug at each of our pharmacies, and our electronic medical record has that ability to do that easily. So those are all the steps that take, and that's why it takes so long. Then there's a very robust communication process that is sort of structured. We have very well-established channels for communications to our stakeholders at these many medical centers and several clinics with their local leaders. The local teams then receive all this packaging, right, this packaged material, but then they customize it to meet their local needs, the local culture, so that the implementation is really personalized. We then have a well-defined process of follow-up, tracking progress, assessing glitches. New evidence is coming in daily. So, keep track of new evidence, make necessary updates, adjustments, and then follow that same process again of, endorsements and communication. So it's really an ongoing process that keeps going. Again, while all this is going on, always a really keen eye on safety, efficacy, and monitoring real outcomes for our members and our patients. We also encourage and review feedback again and again through very defined pathways. We have abilities to get feedback from very, very frontline physicians and pharmacists that we take seriously and account for it. Let's go to the next slide. Again, here I'm describing our formulary management process. Again, very collaborative, very physician-driven, very evidence-based, dynamic, which we all have to be in today's world. There is a group of pharmacists in our drug intelligence and strategy department that are highly trained. We call them our pharmacy research evidence analysts, PEAs, we call them. They really, do their evidence review, partner with our subject matter experts and stakeholders, and department chiefs and chairs that are relevant to the drug that they're looking at. There is a feedback loop that allows input from frontline physicians. So every time a drug is being reviewed for a P&T decision, there is enough room for getting feedback from relevant frontline practicing clinicians. Any physician in our system, we just in Northern California, we have over 10,000 of them, can request a review for a formulary for a particular medication, and it will go through the same standardized process. Formulary decisions are again based on value, evidence, quality, safety, and then cost effectiveness. Our contracting and purchasing aligns with this evidence-based clinician-driven formulary and preferred drug choices. So, we really start with evidence, start with endorsements, and then go to contracting and purchasing. It's not the other way around. Our physicians have the privilege, like I mentioned, and the autonomy to prescribe without the PA. I think that's really our star in our system. And all of this is always conflict-free. We really take great pride, like I said before, in that. Next slide. All right. So this is, again, the basis and really the crux of our academic detailing, a position unique to our system called drug education coordinators. This is, they're a team of residency-trained clinical pharmacists. They work hand in hand with physicians in individual medical centers to promote evidence-based, safe, and cost-effective prescribing. They use tools and data to analyze utilization trends. They identify areas for improvement. They come up with ideas and for initiatives for drug use management. They are really the key players to implement our initiatives that I described earlier. They create and provide educational material and tools, both for providers as well as for patients. Again, very evidence-based. They develop reports, they develop dashboards, presentations that help with decision-making and really provide that visual representation of data that helps, busy clinicians figure out what to do next. The most important thing I really want to highlight here is the foundation of their work is built on a deep trust the physicians are able to have in their work. I'm a practicing internist, primary care physician, and my drug education coordinator at my facility in Fremont in Northern California is my go-to expert for everything pharmacy. It may be a question about a single prescription for an individual patient or a new pipeline drug that I saw on my social media feed. Anything, and I go to my deck. We call them decks. And, they are so amazing at, being able to go beyond their scope of work. Their primary work is really drug use management, but they go beyond that and are able to provide us that support. And by doing that, they allow us to trust them, when they come to us with their drug use management initiatives, and we're able to sort of, have a very trusting partnership to achieve our common goals. And again, keeping the member at the center always. Their secret sauce to their success, with influencing optimal prescribing, again, the resourcefulness, their patient-centric approach, their deep pharmacy knowledge, and above all, that wonderful rapport that they have with individual physicians, chiefs, and departments. It's almost like, although the drug education coordinator is for the medical center, every department thinks that they are their own. They think of them as a part of their department that they can call, they can curbside at any time. And it's really wonderful to see. It's very grassroots level. And I practiced at a county hospital. I was an attending physician at a residency program. And when I joined Kaiser, I was just floored by this particular individual and how much support they can provide behind the scenes. Again, they drive very positive, measurable change, and they, like I said, very, very integral. Next slide. I'm going to quickly detail out, the type of communication and education we do, because, we have no prior authorization. So we really have to do our evidence-based prescribing, our cost-effective, value-based prescribing via education, right? Via behavior change, via culture change. And knowledge and information is really empowering, right? So we use this principle in driving physician behavior towards practicing evidence-based medicine. We are very sensitive to the pressures that our frontline physicians face, workload, throughput, patient expectations, direct to consumer marketing and advertising. We understand the importance of physicians needing to build trust with their patients, and also the importance of physicians needing to trust our internal processes so that they can adopt them confidently in their patient care. We use pretty innovative ways to educate and inform our colleagues. We enable them to understand and enable them to adopt the formulary or preferred therapies or treatment recommendations that we develop by the processes that I described in the previous slides. We do. Our efforts range from basic FAQs and reading material to colorful flyers, newsletters, innovative videos, a blinded and unblinded peer experience sharing. That's pretty solid and valuable. CME sessions, right, by our own internal experts and sometimes external experts, one-on-one discussions. And another key thing we do is we engage very trusted and experienced thought leaders and colleagues to influence behavior change. We'll invite, say, an ENT physician if we want to talk about avoiding antibiotics in sinusitis, and somebody who's trusted in the medical center, right, where our newer primary care physicians can really learn. We do shadowing sometimes. And while the physicians definitely have flexibility and autonomy to prescribe what they feel is clinically appropriate for an individual patient, there is references and links to evidence-based prescribing even in our electronic medical record. An example would be, our electronic medical record having antibiotic choices that are lined up as per our local antibiogram and standard evidence-based recommendations that come from, our infectious disease societies. Again, patient-facing materials are also important. We create these. An example would be, importance of diet and exercise and weight training prior to initiation of anti-obesity medications, which are just adjuncts. So we've developed some wonderful material to help with this in the last couple of years, as as we grapple with how to manage obesity. We develop talking points for our physicians to help with our conversations. An example would be, talking points as to why antibiotics are not needed for a viral URI, or why is it important to taper opioids, or why is it important to prescribe high-risk medications in the elderly. So, giving these talking points really allow our physicians to make powerful conversations in the short time period that they have while they're dealing with 10 other problems that a primary care physician has to do in a 15-minute visit. So we really make that process efficient. Next slide. And I think this is my last slide. This is just an example I want to give to that brings everything that I said together. We use all of the principles that I described to create our oncology pathways. Are we short on time? I can stop right here.
You can finish this one on up.
Okay, all right. So basically, we have these oncology pathways, which we collaborate with our clinical leaders. It is integrated into our electronic health record, and we have a very high uptake on these because of the trust and the partnership that we have. I think I'll stop right there, and I don't know if there are time for questions, but happy to answer them in the chat.
Please do put questions in the chat or put your video on and be prepared to unmute if you'd like to speak and ask the question verbally. I see Jerry has unmuted, so I'm going to turn it to him.
I just want to say how in love I am with this model, and it really deals with so many of the issues we've been talking about today and yesterday so magnificently. I once asked Samir, who I guess has retired from a similar role at Kaiser, if doctors can prescribe anything and there's no prior auth, how do you make sure that they're doing the right thing? And his answer was twofold. One is that education is provided through the academic detailing program, but also the sense that everybody's on the same team at Kaiser. And it's not like the PBM versus the pharmacy versus the prescriber versus the hospital versus the physician, that everybody, from what I can tell, at Kaiser is in the same tent and pulling in the same direction. And that this presentation has made clear how sensible that is and how really communication, education, and evidence can be a great replacement for all the ridiculous incentives and pressures and coercion that mark a lot of the rest of the healthcare system. So thank you for all this great work.
I appreciate all of you and for being pioneers in this work. So it's because of you all that we are able to do what we do. Thank you.
Thank you.
Thank you so much. If there are any further questions for Dr. Okade, please put them in the chat and we can triage them. We have one last presentation for the think tank. Really quickly, what is the biggest challenge in evaluating academic detailing? Go ahead and pop that into the chat box. And while you do that, Mike will be introducing Victoria Kobokis.
Fantastic. So we go from Kaiser. We take a bank shot off the Pacific Ocean and come on back to the Midwest, specifically the University of Illinois at Chicago, where Victoria Kobokis is a PhD candidate in the Department of Pharmacy Systems, Outcomes, and Policy. She brought to that her Doctor of Pharmacy degree that she got at UIC. She's done lots of work in the academic detailing space, especially thinking about the development of validated instruments. She's also thought about and studied patient-reported outcomes, quality of life research, and implementation science. So it's a great background to close out this think tank by thinking together about measuring what matters, evaluation best practices in AD. Over to you.
Thanks.
Right. And Victoria, really quickly, what we have in the chat for your first poll is data availability, clients completing a survey, isolating your impact on data versus other competing messages or groups, provider conversations not being standardized, response rates depending on how your evaluations are delivered. And I'm sure, Victoria, as the expert in this, you know there are many more challenges to this. So go right ahead.
I wouldn't say expert, but I'm trying my best. So thank you all for the great introduction. So today, we'll summarize findings from interviews I had with AD programs inside and outside of the United States. We focused on how they evaluate their work and what challenges they face and where they see opportunities to strengthen potential evaluation practices. So I do have some disclosures here. I'm currently supported by the UIC AbbVie HEOR Fellowship, and my team has previously received funding from the CDC. And then furthermore, the PSAT and DAVE instruments I'll reference later on in the presentation were developed at UIC, but they are free for nonprofit use. And so these views expressed in the presentation are those of myself and not of any funders. All right, and so I'd like to acknowledge my mentors, collaborators, and the NaRCAD network, as well as all program representatives who participated in my study. Their insights and lived experience form the foundation of this work. And so let me walk you through what we'll cover today. We'll review our purpose and methods, summarize common evaluation practices and approaches, highlight challenges, share key insights from the programs, and then end with tools, recommendations, and conclusions. Let's see here.
You have a waterfall.
This is what I was waiting for, yeah.
Yep. Does your AD program currently conduct any formal evaluation? A, for yes, regularly, B, for occasionally, and C, for not yet, D, for NA. Let's see what we've got. Lots of A's here. 1B, mostly A's. Yep. We have 1C, couple C's. All right, it looks like mostly A's, a sprinkling of C's, and 1B so far. Back to you, Victoria. Keep it coming.
Great to see. So on to the next slide, we can say, talk about why evaluation matters, right, in academic detailing. So evaluation is central to demonstrating the value of AD. Programs rely on evaluation to understand provider satisfaction, track engagement, assess behavior change, and justify continued support. And at the same time, many programs do struggle with limited tools, inconsistent measures, or challenges to accessing meaningful data, as we've seen in the chat earlier today. But but our study set out to better understand these realities. Next slide. Our objective was to understand how AD programs evaluate their work, and the aims specifically were to describe the current methods used, identify common challenges, explore use of standardized tools, and then highlight practical opportunities to strengthen evaluation for all programs, right? So here's how we approach that in the next slide. We conducted semi-structured qualitative interviews with representatives from 14 AD programs recruited through the NaRCAD network and then through some professional connections. Interviews were conducted virtually, recorded, transcribed, and independently coded using the framework method. And then here you can see we use the REAIM implementation science framework to guide data collection and analysis, which helped us to explore evaluation across domains like reach, implementation, and effectiveness. So yes, to give context to the findings, let me briefly describe the programs that participated. And here we go. The programs varied, in geographic region, size, maturity, staffing structure, and then clinical focus. Some were long-standing and well-resourced, while others were newer or smaller. And topics were chosen by these programs based on provider feedback, practice gaps, new evidence or guidelines, and priorities from funding organizations or health departments. And then here's some additional program characteristics included diverse funding sources, varied target audiences, and then both mixed use of both in-person and virtual detailing formats. Let's see, and then here's another poll for you all.
What evaluation methods do you use or would you like to use? A, and you can put as many as apply to you. A, provider satisfaction surveys. B, prescribing or claims data. C, qualitative feedback. D, activity tracking. And we'll see what we've got. Trish says all of the above. Lots of people are loving A, B, and C. Yep. Talking about what people are currently using. Yep. All right. So Victoria, you can see that A and C are definitely steadies. Got a couple for B and a couple for D. But really hoping it seems like most people want to use as many as possible. Back to you.
Sure. So now we can look at the evaluation practices that the programs I spoke to were using. Number one, and most commonly, was the post-visit surveys. Programs used a mix of satisfaction-based surveys and also knowledge-based surveys. And then we saw prescribing and claims data being used to assess behavior change. And this could be viewed as the gold standard, in quotes, by some programs for assessing behavior change. However, many programs did struggle to obtain it. And then we have here visit tracking and then qualitative feedback. All programs track basic metrics such as number of visits, provider types, and repeat visits. And then in thinking about qualitative feedback, we found that stories, provider comments, and informal feedback were universally valued and often considered, as informative as quantitative feedback. So, oh, one more, let me see if I had something else to say. No, that's okay. We can move on. The quotes
All right.
are gone.
Of these barriers, what's the biggest to evaluating your AD program? Is it A, limited staff capacity, B, a lack of tools, standardized tools, C, a lack of training or expertise, or D, it's just not prioritized? And if it's something else, go ahead and pop it in the chat. All right, seeing a lot of limited staff capacity, seeing quite a few for it not being prioritized, seeing a couple for a lack of training or experience, but a lot of A and D. Very much not as much an issue of a lack of standardized tools we're seeing. And then Sally is adding clinician burnout, so there's no time or energy to complete the surveys. Yep. And then we have a few extra pieces here. Narissa saying understanding how to effectively analyze data. So that might be some training or expertise, changing needs of the project, and not being able to actually capture it. All right, keep them coming. Back to you.
Sure. So programs in the study describe 4 major challenges. Survey fatigue, even short surveys have very low response rates. Data access issues, as we've, are always talking about. Prescribing and PDMP data is restricted, expensive, or resource intensive. And then there are standardization gaps, right? So most programs create custom tools, but this can lead to inconsistent measures. And then a lot of the times, we want to be efficient, right? And we cover multiple topics in our visits. But in theory, that is hard to attribute the outcomes from those visits when we're looking at multiple topics during one session. So despite these challenges, many programs have expressed interest in, more standard evaluation tools, although the survey may not have showed that. So we can move to the next slide, Devin. Okay. And so before getting into these results, and so everyone's kind of on the same page, I'd like to say that using a standardized survey tool is kind of like using a ruler instead of measuring with your hands. So the ruler will give you consistent, reliable measurements every time, while measuring with your hands might work. It might be imprecise and vary from person to person, right? So keeping that in mind, out of the programs we talked to, 5 AD programs reported awareness of validated tools, and study participants identified benefits such as including, research credibility, time savings, standardization, and easier comparisons across topics or time. But it is important to note that programs still do want that flexibility to add topic-specific or CME required items, and emphasizing, keeping those surveys short, trying to decrease any provider burden. And so, yes, perfect. And these tools do help measure the visit, right? But they don't replace an important part of AD, which is the relationship between the provider and detailer. Participants did talk about the value of simply giving space to share what's on their mind. Clinicians, I mean, whether that's feedback about the visit or what they're dealing day to day, that opportunity for open subjective input really matters to them. Programs also describe their approach to being more provider-centric instead of starting with, here's what we want to cover. They begin with the clinician's goals, their needs, and what's happening in their organization, and then potentially connect back to AD services. And then another theme that came up was the emotional side of the relationship. In today's clinical environment, clinicians often just need someone to listen, right? Even if that means letting them vent for a moment, and programs see that as a part of building trust. And finally, many programs do view repeat visits as a clear sign that the relationship is working. If a provider wants you back, that's a strong indicator that they see value in the interaction. So drawing from these insights, we summarize several practical recommendations that were given directly by the participants, not just myself. Across all interviews, we heard that, first you got to start with the basics. Tracking things like visits, duration, satisfaction, and follow-up rates might seem simple, but programs told us these metrics go a long way in showing their reach and their provider engagement. Second, many programs found value in partnering with evaluation experts or using validated tools to bring more consistency and rigor to their process. Third, we'd like to keep relationships front and center. The qualitative feedback, the comments, the stories, the provider impressions often gave programs some of the most meaningful insights, right? And then finally, if you can, invest in whatever data systems you have access to. Even small improvements in tracking or documentation can make evaluation easier and more reliable for a lot of groups. So one way, to put these recommendations into practice is by using standardized tools that are already available, like specifically for AD. So here we have the PSAT, or Provider Satisfaction with Academic Detailing instrument. It is designed to capture the clinician's perspective, like how useful the visit was, how relevant the content felt, and whether the detailer met their needs. So programs do like it because it gives them a consistent, validated way to understand provider satisfaction without necessarily reinventing the wheel every time. And then there's the DAVE, or the Detailer Assessment of Visit Effectiveness. And this one captures the detailer's perspective of the visit. It helps document what the detailer observed, the provider's engagement, whether goals were met, and how effective the interaction felt overall, right? And so together, these tools give programs a structured, balanced view from both sides of the visit, if both are used. And then what programs really appreciate is that these instruments are already vetted and validated. They're ready to use, they save time, and they bring more rigor and credibility to evaluations, which could potentially, set up the scene for getting grants and funding and like such. So these tools are a great starting point. I'm a little biased, but that's okay. They fit into a bigger picture, right, of evaluation rigor, which brings us to a hierarchy that I'm developing. On the next slide, please. Yes, so this is in development, and we did see a hierarchy of evidence in the first presentation, and this reminded me of that as well. So we're working on this draft hierarchy, right, that helps programs think about evaluation in terms of feasibility and then rigor as well. So at the foundation, we have the basics, like mentioned, visit tracking, satisfaction measures, and qualitative feedback, which every program can collect and still provide meaningful insight, right? So as you move up the hierarchy, you do get into more structured approaches like validated tools, and at the top are outcomes like prescribing or claims data, which offer the strongest evidence of behavior change, but also it could be hardest for programs to access, especially if they're not necessarily integrated into a healthcare system, right? So the goal of this hierarchy isn't to say, every program needs to reach the top, but it gives a framework for understanding where different evaluation methods fit and how programs can build step by step toward greater rigor when possible. And so to summarize some key takeaways here, in conclusion, AD programs do use diverse evaluation methods. Surveys and visit tracking are the most common. Prescribing data access remains a major barrier across many programs. And then provider relationships are central to program success, and then standardized tools could offer a way to greater consistency. And with that, I'll say, looking ahead, our next steps are to really take what we've learned and make it more actionable for some programs. So we'll continue to refine that evaluation hierarchy. And then we're also working on supporting broader adoption of validated tools such as the PSAT and DAVE, especially for programs that want more consistency but may not have a dedicated evaluation staff. And finally, we want to keep collaborating with AD programs to further refine these tools for continuous improvement. And so with that, I'd like to take a moment to acknowledge the people who made this possible. I'm incredibly grateful to my research team, our collaborators, NaRCAD, and especially the 14 AD programs who participated and shared their time and experiences with us. Their perspectives made this project work, and it was amazing. Thank you so much. And with that, I'll wrap up with my contact information and both instruments here if you'd like to read more about them. But happy to, send me an email, chat anytime. Would love to hear some feedback.
Wonderful. Thank you so much. That was fantastic. And I remember you reaching out to ask for a couple of more programs to participate. What a wonderful project that we can all learn so much from. Any questions as I know we have to move into a break. So what we can do is, for those of you who want to go right into your break, you're welcome to shut your video off and maybe keep your audio on if you would like. Those who would like to stick around and pop questions in the chat to Victoria, Jackie, Yahaira, or Neela, please do. We do have a question from Aaron here, or more of a reflection. Aaron says, I always wonder how much relates to our skill in knowing what quality clinical data looks like. And we can recognize how weak much of our own internal surveys likely are. Any reflections on that, Victoria, that you'd like to share?
No, it seems, surveys are easy, right, to think of what you would like to measure. But yeah, like same in the first presentation, the reliability and validity targets, that's exactly what I could have put in my presentation as well. So love to see it.
And Jerry, you have your hand raised. Please unmute.
Okay, I think I am unmuted.
Yes, you are. Go for it.
I have, thank you, Victoria. That was a really good presentation. I think many of us are wondering about the copyright that's emblazoned across the materials. Does that mean that people can use it as long as they attribute its origin to you folks, or does one need special permission and payments and stuff like that to use those instruments?
Sure. So no payment is needed, but in those QR codes where for the PSAT and Dave, it sends you to an email at UIC, and they'll, like, just to track who's using it, they'd like to, get you to ask for permission that way. But it's free to use. We would just like to, track who's interested in using it. So
No, that's fair. I think it might help if you were to explain that, because most of what people saw was copyright.
sure. Sorry to scare everyone. That was my advisor's my advisor's comment. You should put copyright so people don't just, take it and use it right away.
And then just
pay the troll toll.
And Bevan can put a link in either the chat or in the materials that since we had our last meeting in November, my colleague Ben Rome and a number of us at ALOSA and at the Division of Pharmacoepi did publish something in one of the JAMA journals that was an evaluation of everything that had made it into the literature evaluating academic detailing programs that was methodologically okay. Or better. And Bevan, if you can circulate that link, people I think on this call might be particularly interested.
The systematic review, yes. Welcome back to our final session of NaRCAD 2025. We're so excited that you're all still with us, and I'm loving just scrolling through the chat and seeing the ways that folks are cheering one another on, sharing links and resources, reflecting on each other's work. And really appreciate the incredible folks who just spoke as part of our think tank, really giving us new ideas to think about how we curate the best evidence, how we deliver it, and how we evaluate it, especially when there are things like survey fatigue and burnout and a need for more systematic tools. So thank you so much for all of the wonderful resources that have been shared. My running Word document of shared links is now on page 3. So you all will be getting a very juicy attachment when you get your post conference email from me. But in the meantime, there's still one more to go, and we are so honored to have this fantastic group of humans present. May I just say that whether you're working on opioid safety and overdose prevention education or not, this will all be relevant to you, because we've got 3 fantastic presenters from really well-established programs talking about the work that they've done. And there are going to be so many translational approaches that you can use, that you can start thinking about. And these are really innovative approaches that you will get to learn more about momentarily. But before we do that, some of you will know these answers more intimately based on the work you're doing, and some of you may have a sense just based on being in the world right now. But please do pop on over to the chat and answer this question. Currently, what do you think the biggest gap in clinical care or clinical knowledge is related to opioids? The other way to look at this question is, what do you wish clinicians knew or did differently? We've got 4 in a row for stigma. So we know that that is a challenge. Now make that 5. Danielle says coordination of care. Vishal says knowledge of different options. Heather, so great to see you, Heather, shares access to resources. Yes. Elizabeth's sharing inertia in high prescribers. Yes, clinical inertia for sure. We've got more being shared about clinical knowledge around how to taper safely. What else feels like a challenge right now where there's a large gap in clinical care that an academic detailer may be able to fill? Kyle says knowledge of OUD treatment options. Narissa shares prescribing opioids simply because the previous prescriber did. Yes, inherited patients is often a challenge for a clinician, just following suit with whatever came prior. Megan shares provider confidence in the delivery of prevention and treatment options. Tony from Alosa says alternative options for pain and more for tapering. We'll do a few more before we dive in. Dave says clinicians refer to recovery programs only. Yes, which is really the antithesis of looking at harm reduction. So the idea that recovery is the only way to treat opioid use disorder. Keep these coming. These are all great thoughts that just show how attuned you all are. And I will turn it to Mike to introduce the first of 3 fantastic presenters, starting with Finn Black. They are attuned, tuning in 3 hours early from San Francisco. So Finn, great to see you, and Mike, over to you.
All right, thanks so much. All right, so my name's Finn. I'm a registered nurse who works as a research clinician at the Center on Substance Use and Health. We're based in the San Francisco Department of Public Health. So my primary role is in drug user health research, especially issues related to the health of people who use stimulants like cocaine and meth. But I'm also part of this academic detailing program called the Center for Innovative Academic Detailing on Opioids and Stimulants. Acronym doesn't even spell out our name anymore, but don't worry about that. So our primary goal is that we educate providers about best practices in caring for folks who use drugs. And outside of work, I've been working in the harm reduction field for about 15 years and volunteer as a nurse at a couple different syringe exchanges in San Francisco and over in the East Bay. Next slide. So no financial conflicts of interest to disclose, and any opinions I present here today are my own and don't necessarily represent the views of the San Francisco Department of Public Health. Next slide. Okay, so just to give a brief overview of what our program is and what we do. We're an academic detailing program hosted within the Center on Substance Use and Health, and we provide support to anyone in San Francisco, whether or not they work for DPH, if they work with folks who use drugs in any capacity. So medical providers, nurses, pharmacists, therapists, case managers, but also frontline staff and peer workers who might not have any specific clinical credential. So as long as you work in San Francisco and you have questions about caring for people who use drugs, you can meet with us and we'll work with you on any issue related to drug user health that you want. We mostly do one-to-one sessions. So our usual strategy is we'll visit a clinic, present at an all-staff meeting, give an overview of our services and whichever campaign we're currently focused on, and then try to follow up with individual clinicians and staff to do one-to-one sessions. And we'll meet on any topic related to drug user health, but we usually have a main detailing campaign that we're focusing on. So right now that's supporting clinicians in prescribing buprenorphine for opioid use disorder, because once we got rid of the X waiver a few years ago, we suddenly had a lot of clinicians who were able to prescribe buprenorphine, but didn't necessarily felt like they had the education or the tools to do so and felt intimidated because of a lot of people having higher opioid tolerance from using opioids like fentanyl. And some of our previous campaigns included getting more prescribers to be comfortable co-prescribing naloxone to patients who are on opioids for chronic pain, and best practices for working with patients on long-term opioids for chronic pain. All right, next slide. So just to give you a background of what I'm going to talk about today, I think everyone is aware that in San Francisco, like the rest of the country, there's this ongoing opioid overdose crisis. And the whole country saw a large increase in fatal opioid overdoses when fentanyl began to appear in and then replace heroin as the main opioid in the street drug supply. Fentanyl arrived in different regions at different times, mostly moving east to west. So in San Francisco, it really started to become more common in 2017 to 2018, and we had this really big spike in opioid overdose fatalities. There's a number of different public health interventions for preventing fatal overdoses, and one of those is making evidence-based treatment for opioid use disorder more accessible to people who want it. So medications for opioid use disorder, we call them MOED for short, include things like methadone and buprenorphine. They're some of the more powerful tools that we have for reducing someone's risk of a fatal opioid overdose, and either of those treatment options reduce someone's risk of dying by about 75%, which I think I have on the next slide. And then if you go to the next slide, so in San Francisco, fewer than 1 in 4 people with opioid use disorder are on medication for MOED. This isn't that better than the national trend of 1 in 5, even though we're a really dense urban area. Geographically, we're not that large. There's a ton of resources, and we have a really robust public health clinic system in the city and a healthcare system for people who aren't eligible for federal insurance. And just to provide a little bit of context for folks who are a little bit less familiar with MOED, methadone is a long-acting opioid that's really effective for treating opioid withdrawal and cravings, but federal regulations have mostly siloed it into methadone clinics, which can have really challenging hours and strict policies that pose access barriers to a lot of patients. Buprenorphine, which some people also know by one of its brand name formulations, Suboxone, can be prescribed in primary care settings, but historically it came with its own set of regulations. Providers had to undergo extra training, get a special waiver from the DEA to prescribe it, and that ended up being a really big barrier to access, as most providers weren't able to prescribe it. In 2023, those requirements were eliminated, but prescribing buprenorphine can be kind of complicated and intimidating to a lot of providers. So there were a lot of folks, even in places like San Francisco, who needed support to feel confident. And that's why Chow started focusing on buprenorphine detailing. All right, so if you go to the next slide. So in 2024, the San Francisco Department of Public Health came up with this program to try to kind of bridge some of the gap. So, we had been out there with our campaign trying to get the word out about how to start and continue patients on buprenorphine. And then the city came up with this program called Building Expanded Access to Buprenorphine, BEAM for short, to help address some access barriers. And the idea with BEAM is that there would be this team of frontline health navigators walking around the streets at night, mostly in the Tenderloin, to engage with people outdoors and offer them an on-the-spot telehealth appointment for buprenorphine if they wanted to get on it. And they would get a prescription for buprenorphine called into the Department of Public Health's community behavioral health pharmacy. And in order to staff these telehealth lines, they were going to hire 70 medical providers. And deploying this many providers rapidly meant they were going outside the addiction medicine field. So some of the providers were coming out of retirement to do this. Some were working in other settings and wanted to take on some evening work from home hours. So they were mostly working in occupational health or urgent care. And a lot of them were completely new to treating opioid use disorder and working with this population. All right, next slide. So since there was this need to train a large number of providers, we got tapped to individually detail every provider who was new to the field of addiction medicine. And getting detailed was made part of the required training, which is interesting. So, we're normally trying to convince people to do detailing sessions with us, but in this case, they were actually mandated to do detailing sessions with us. So they got up to 2 paid work hours to meet with us and had to complete at least 1 hour of detailing sessions. So we got a list of core clinical competencies that providers had to meet, but we're basically left to our own devices for how we wanted to go about detailing them and how we wanted the system to work. So what we ended up doing is, for most providers, we split those 2 paid hours into roughly 3 sessions. So first we met with them to do an initial learning assessment, get a sense of what they already knew about buprenorphine, what their main concerns were, what they wanted to focus on. Mostly those sessions involved a basic overview of the pharmacology of buprenorphine. Then we did a second one to process what they learned after they shadowed their first telehealth shift. So part of their training is they would shadow an experienced provider, listen in on a bunch of telehealth appointments, and then they would meet back with us and we would talk about how did that go, what came up for you, what did you learn, what are your questions? And then we did a third session once they'd completed their first shift and had actually prescribed buprenorphine for the first time to see how they were feeling about it. And for some providers, we focus more on pharmacology, but we also had a lot of sessions where we just discussed things like rapport building, stigma, all of the complexities of trying to do telehealth with someone who is on the streets of the Tenderloin at midnight in a very public space and possibly in an altered state of consciousness. So this required a lot of flexibility on our part to meet all of their needs. All right, so next slide, just kind of talk about how this ended up turning out. We ended up training 26 providers, so there were a lot of the 70 who already had existing experience. During the session, something that came up was a lot of providers shared their ideas for how Beam could be improved. So a really big thing that providers were observing was that this rapidly deployed a bunch of folks to prescribe buprenorphine, but there wasn't really a plan in place for what you were going to do after that person's initial week of buprenorphine ran out. So they would call on a script, they would go to the community behavioral health pharmacy, pick up the first week, and then they were expected to self-link to a primary care clinic so they could continue it. So we had a lot of providers expressing concerns about the lack of sort of robust follow-up in this program. So we were able to contact the leadership, organize a bunch of listening sessions with the provider, and then they ended up totally restructuring the program. So it was kind of cool that we were able to be this sort of neutral third party that was within DPH, but not directly related to the program, but in a position where we could advocate and relay provider feedback back to the higher ups and help facilitate change. And then final slide. Another really interesting thing that came up is while we were talking to the providers, they told us that the frontline staff who are out on the streets doing navigation also wanted to learn more about buprenorphine, and that some of them might have been providing not totally accurate information to the clients they were meeting with on the streets, or setting up certain expectations for how their buprenorphine initiation was going to work or how to take their medications. So we ended up holding 2 in-person group trainings for the frontline staff to help correct some misconceptions about buprenorphine and just have a conversation about sort of scope of practice and like, you know, how to support someone in starting bup without necessarily taking up a clinician's role. And then that also led to us being asked if there could be more educational material to hand out to clients. So we had this whole other campaign where we developed a bunch of patient-facing materials that navigators could share with clients out on the street, which my colleague Rebecca presented on yesterday. All right, so that is the meat of the presentation. Do any folks have questions?
All right, just unmuting. Anyone have questions? I know Mike does, but let's give a moment for people to put things in the chat, raise their hand, and just see, you know, what other reflections there might be. I see lots of clapping happening with the little clappy emojis, so that's lovely. Thank you, Finn. While people are putting their questions in the chat, Mike, I will throw that over to you.
Yeah, Finn, thank you. Wonderful presentation, really innovative program. I was intrigued when you talked a little bit about that sort of bi-directional feedback that you can, it can be a really effective detailing program. And you can also sort of, I think the way you said it, that was really interesting, sort of feedback to the higher ups, you know, that it can be. Can you say a little more about that in-between role, how sort of information can go in both directions, and how you all in your team might be using that going forward as you keep doing innovative stuff?
Yeah, I think that it's a really good question. I think we were in a really lucky position in that we knew the directors of the behavioral health services who were administering Beam and had met with them before about our program and had even detailed them. So like some of the staff who are kind of in the higher ups already had a relationship with us. So it was really easy for us to reach out and be like, hey, this is an amazing program that you have. We do have a couple of concerns that we're hearing from providers that we'd like to relay to you. And it might not always be the case that you're in that kind of position where you can give that feedback and already have like existing trust and relationships that makes it a little bit easier to do.
Yeah, that's really helpful. I mean, it strikes me as being sort of, I mean, it speaks so much to how trust and knowing knowing the groups that you work and collaborate with in the community makes such a difference. It's sort of, there's the presentation before the break from Kaiser where they're all one big integrated system. Usually in public health, that's not the case, but clearly you all have these sort of deep relationships and that trust, and it makes such a difference. Really great work.
Finn, I have a quick question. I saw, of course, your the fantastic qualitative feedback and just the ways in which clinicians found this so valuable. Did you have any pushback? Did you have anybody kind of say, hey, I don't want to do this, especially with it being mandatory.
Yeah, and we actually are currently in the middle of another campaign where a number of staff who are being moved from one department into DPH have been mandated to meet with us. We do occasionally, when this happens, we do occasionally have folks who are like, I don't see the point, or I'm not sure what I can get out of this.
Mm.
And we try to be really flexible and receptive and say, like, here's a general overview of what we can offer. I want to make this useful to you. I don't want to make you feel like you're wasting your time. And even when we've had folks who are initially resistant, usually people end up finding that there's something that they want to talk about that ends up being useful for them.
Mm-hmm, mm-hmm. Yes, it sounds like once they see it as less of, hey, I'm here to give you information, and more of a, this is a space for me to talk about what I'm experiencing, they are able to see more value. And Katie is saying it's mandated, but at least it's paid, which is, yeah, imagine mandated and not paid. Also some comments for loving the passion that you bring, Finn. Thank you so much. And if there are any more questions for Finn, please drop them in the chat box. Thank you so much.
Absolutely. Thanks, y'all.
All right. So we have another chat waterfall question before our second of these 3 presentations. What do you think stresses pharmacists out the most? Or what factors contribute to pharmacist burnout? And this can be in any setting. What do you think stresses out a pharmacist? I see people typing. Insurance claims. Thank you, Paul. Volume. Yes. Not enough time to complete all the tasks. More for volume. Productivity expectations. Overwork. No time to educate patients. Yes, it's a big part of their job. Patients themselves, misuse of prescriptions, high workload, metrics, and filling as many scripts as possible. High workload paperwork when the prescriber does not explain the medication being prescribed. Over the top pop-up warnings, easy to make mistakes. Yes, these are just a few. Keep them coming. Pharmacy consolidation. Paul, as a pharmacist, of course, you're going to be popping multiple complaints in the chat. Lowering of staff, being stuck in the middle, having to be the front person for dysfunction in the system. Yes. Increased scope without additional support staff. The retail world equals no bathroom breaks, prior auths, filling the incorrect meds due to stress, and being overwhelmed. Wow. Yeah, that's a lot to deal with. Just thinking in general about, you know, what they're up against. We talk a lot about PCPs, but important to attune to pharmacists. And with that, we will be talking about building a bridge, engaging community pharmacists with AD mini visits. Mike, over to you to introduce Monica Roberts from the University of Kentucky.
Yeah, very excited. Really fun for our BMC-based NaRCAD team to be introducing Monica Roberts. She's an academic detailing pharmacist at the University of Kentucky. And she developed and delivered this prescription opioid safety educational outreach program as part of the Healing Communities study in Kentucky. This was a very large 4-state collaboration. The coordinating center was actually here in BMC, just on the same floor where I'm sitting right now. So it's wonderful to hear from the Kentucky team this afternoon. Dr. Roberts now works on several opioid-related projects at University of Kentucky. She draws on her experience in clinical pharmacy, but also we've been talking over the conference about sort of the breadth of backgrounds. She has a background in journalism and publishing as well, and brings that perspective to bear. So she's going to be speaking to us about building a bridge, buprenorphine resource initiative for dispensing, guidance, and education, a wonderful acronym, engaging community pharmacists with AD minute visits. Monica, over to you.
Thank you. I'm so excited to be here and talk about our P2P Bridge program and how we kind of tried to adapt academic detailing to the community pharmacy setting with this idea that we call mini visits. If you want to get a closer look at any of the stuff that I'm talking about, our website has all of our materials on it. So as I'm flying through stuff, if you want to see something closer, feel free to check that out. First, I'll explain these 2 acronyms. So P2P is pharmacist to pharmacist, and this is our model for educational outreach to community pharmacists specifically. And in P2P, we combine mini visits, which I'm going to explain, with full-length traditional continuing education activities to kind of give a holistic approach for pharmacists. But the goals are just like any academic detailing program. We want to improve practice, develop relationships, and just be a resource for the folks practicing out in the field. Bridge is the specific initiative where we implemented the P2P model and tried to test the P2P model. It was a formal research project with an objective to mitigate pharmacy level barriers to buprenorphine dispensing. We had 2 planned analyses, pre and post surveys, which I have data from, and then we were going to look at dispensing data from CASPR, which is the Kentucky PDMP. That has taken substantially longer than we thought it was going to, so I don't have PDMP data today, but hopefully we'll get it someday. Next slide. I want to acknowledge that this project, Bridge, was funded by the Foundation for Opioid Response Efforts. We are very appreciative that they gave us money to do this. Other than that, we don't have any disclosures. I also want to acknowledge our awesome Bridge team. We had 6 pharmacists who all brought very unique skill sets to this project, and we could not have done this without all 6 of us. Next slide. So you all kind of answered this question, why not traditional academic detailing for community pharmacy? Community pharmacists are kind of hanging out on the red and pink side of this graphic. They do not have the capacity or the availability to really be pulled out of practice for any length of time during their workday for traditional academic detailing. Burnout is high across healthcare, and unfortunately it is highest among pharmacists, even higher than nurses or, nurses or physicians. And since the pandemic, it's gotten more stressful and harder for community pharmacists with increased workload, exhaustion, and mental health disorders. I left community pharmacy in 2019. I didn't think it was easy then. So the fact that it's gotten so much worse since the pandemic is really a sign that folks are struggling out there. The P2P team also knew that academic detailing in community pharmacies was a challenge because we tried it during the Healing Communities study. So for the first phase of the Healing Communities study, and you can go ahead and show that next animation there. The first phase of the Healing Communities study, we had 170 community pharmacies in that wave. And we did some pretty extensive recruitment to try to get people to schedule virtual academic detailing related to prescription opioid safety. And over the course of more than a year, only 11 individuals participated. So mini visits were kind of a trial and error effort in the second phase of the Healing Communities study, just trying to figure out what we could do to connect with community pharmacists. And then in Bridge, we sort of formalized the whole idea and created the P2P model. So we'll go to the next slide and I will describe mini visits. They are unscheduled, incredibly brief. I'm talking 5 to 10 minutes max, interactive visits with the pharmacist on duty. Whoever is working at the moment that we walk into that pharmacy, that is who we talk to. We plan the topics and we do a series of visits. We try to have kind of one key message for each round of mini visits, but we're always going to focus on the pharmacist's needs and concerns. If they say, hey, I have a question and it's not related to the key message, we focus on that. We visit all of the pharmacies in whatever our target region is, and we visit all the pharmacies on every round of visits. So even if somebody's not super engaged, we still go back the next time and say, hey, can I have a couple minutes with you? And the multiple visits is really designed to build that relationship and be a familiar face to the pharmacists. We rely really heavily on our printed materials in mini visits. We want them to stand alone, and we want that for 2 reasons. The first is we want the pharmacists that we talk to share the information with the rest of the pharmacy staff. So the technicians, the pharmacists that aren't working at that moment. And so they need something to be able to pass on and to share with the other folks in the pharmacy. The other reason we rely on our printed materials is because we allow what we call drop-off only visits. So sometimes you walk into a pharmacy and it is clear there is no way that pharmacist has even a moment to talk to you. And in those instances, I just say, I take the packet of materials, I stick my card on top, I say, hey, give this to the pharmacist. When they have a chance to look at it, have them look at it. If they have any questions, feel free to reach out to me. Otherwise, I'll see you in a month or two. And we just go from there. We do this because we really want to be authentically helpful. And sometimes the most helpful you can be is just getting out of the way in the pharmacy and letting them keep doing their work. So that's why we really focus hard on the printed materials and making sure all the evidence and everything is in those materials. Next slide. This is our idealized development process, which we were able to do in Bridge. Before we ever wrote the grant, we did a literature review. We knew from the literature that buprenorphine dispensing was a problem in community pharmacies. Nationally, 20 to 30% of pharmacies say they can't or won't dispense buprenorphine for opioid use disorder. We had Casper data that showed kind of an imbalance between the prevalence of opioid use disorder and the dispensing of buprenorphine in particular areas in Kentucky. And then as part of Bridge, we conducted focus groups with community pharmacists and technicians to see kind of what the barriers they were reporting were, what was happening out on the ground. And to hear what their facilitators were. So for the folks that were doing a lot of buprenorphine dispensing, what was encouraging them to do that? We also had the chance to talk to the Survivors Union of the Bluegrass, which is an organization housed here at UK, made up of people in recovery from substance use disorders. And they make themselves available to anyone on campus or beyond who wants to make sure that the patient experience is included in the work that they're doing. And so they were hugely helpful in talking about what they had experienced at pharmacies and what they really wanted pharmacists to hear about buprenorphine and about substance use disorder. After that, we selected our target counties, we wrote our key messages, and then we entered into this iterative cycle of content development. So for each visit, each CE activity, we would develop the content, roll it out, and then take all the questions that we got, all the evaluation data that we had, the post-test information from the CE, and feed it back into the next round of visits or CE content. So this helped us be very kind of adaptive and responsive to what we were hearing and what our audience needed in terms of education or specific topics. Next slide.
Apologies, it's frozen. Give me one.
Of course.
Thank you for your. There we go.
It is. So we had 23 target counties. In these target counties, at the beginning of the project, there were 116 community pharmacies. Our team has 2 academic detailing pharmacists, myself and Dr. Laura Stinson. We split the counties up so that we visited the same counties each time we went out. So it was a familiar person visiting on each round of visits. Next slide. These are our key messages. If you work in opioid use disorder, these are probably not surprising to you. I will not read them all. I'll just give you guys a second to read them, and I'll take a sip of water. We'll go to the next slide. So this is how the whole thing kind of unrolled. The first visit didn't have any content in it. It was just to introduce ourselves and ask people to take the pre-survey. We also invited them to our first CE webinar, which was kind of a general overview of opioid use disorder. The next round of visits, we brought our buprenorphine question and answer guide, and this was a 16-page booklet where we tried to concisely answer every question that we thought a pharmacist might have while dispensing buprenorphine. We accredited this for an hour of continuing education, so if people read this booklet and scanned the QR code, they could get an hour of CE. We also tried to make it kind of a practice resource. So in addition to answering questions that we thought might come up, we included QR codes to references like the ASAM guidelines or the state prescribing regulations, so that if somebody had a question in practice, they could use this as kind of their buprenorphine Bible, if you will, to find the answers to whatever they were struggling with in that moment. In the third round of visits, we focused on the patient experience. So for this visit, we interviewed 4 patients in recovery on buprenorphine, and we made 4x6 cards, and each card had a quote from one of the patients on the front, and then on the back it had evidence-based information about that quote and pharmacy practice. So you can see the one here is about language and labels. The back of it had information about stigmatizing language and how it affects patients and kind of how to adjust your language to be less stigmatizing when you speak with patients. At these visits, we sort of asked the pharmacists to read the quotes on the front and tell us how they saw those things in practice. And then we just kind of focused in on whatever one they focused on. We would kind of talk more about the evidence base behind whatever was on the back of the card. At that visit, we also invited people to our next webinar, which again was focused on the patient perspective and included clips of those interviews that we had done with the patients. At the 4th round of visits, this was our buprenorphine barriers visit. Again, we used 4x6 cards. We had 4 of them. Each one covered a different kind of technical regulatory type barrier that people had told us was a problem throughout the previous visits. So we had one on suspicious order monitoring, one on DEA red flags, one on coordinating care with prescribers, and one on frequently asked questions about our state prescribing regulations, which are very wonky and hard to manage. So again, we showed the cards to the pharmacist and kind of asked them what they were struggling with and then focused in on whatever was most salient to them. We also invited them to our final webinar, which was called Red Flags in the Real World, and featured a panel of pharmacists and prescribers talking about how to balance those kind of corresponding responsibility requirements with good patient care. Our last visit was supposed to just be a wrap-up and a request for people to take the post-survey. But from November to February, we had a whole bunch of regulatory changes. And so we threw in this last-minute kind of regulatory updates and just checked in to make sure pharmacists had heard about these things that had changed since the last round of visits. Next slide. And then you can show the first set of stuff here. So we conducted 574 mini visits. 80% of the visits took less than 15 minutes. That is exactly as we had designed it. Only 6.6% of visits were those drop-off visits. And I think that's about perfect. It tells me that we were being responsive, but for the most part, we were able to engage with the pharmacist on duty when we visited. It is a lot of travel. We usually gave ourselves about 5 or 6 weeks to get through all of these day trips and overnight stays between the 2 of us. And we visit a lot of pharmacies at a time. So between 8 to 16 pharmacies in a day. I find my limit is about 12 before I get a little loopy, but sometimes geography kind of dictates that we had to do push a little bit more than that. Next section. General impressions, pharmacists were really welcoming. They asked questions, they engaged, they seemed happy to see us. We were worried that this is going to be kind of a controversial topic, especially in the pharmacies that don't dispense buprenorphine. But for the most part, people were really happy to have someone to kind of run things by, talk to, even just to complain for a little bit to someone who kind of knew what they were going through. It was overall a very positive experience. Occasionally, people would reach out between visits. That was also encouraging to me. They had questions about things that we were talking to them about and things that were kind of tangential to what we were talking about. Next slide. We did include in the post survey a validated measure of acceptability and feasibility for an intervention, mostly because Laura and I were very worried that we were going to tick people off and we wanted to make sure that people were okay with this. The percentages that you see on this slide are people who agreed or strongly agreed with the statements. So you can see overall a very positive response in terms of the visits being doable, people thinking they were easy, they liked participating in them, and so on. Next slide. In the pre and post survey, we did not see a statistical difference between the basic question of, do you dispense buprenorphine at your pharmacy? It stayed pretty much the same pre and post, but we did see some changes in willingness to dispense specific types of prescriptions. And the one that was statistically significant was on telehealth prescriptions. I was happy to see this because I think I answered more questions about telehealth and the telehealth regulations than any other topic. So the fact that the willingness to dispense went up on this tells me that we gave some people some confidence and some information that they needed to continue to care for patients who were being treated via telehealth. Next slide. We also had some attitude-related questions. The three that saw an increase, statistically significant increase, were buprenorphine is a maintenance medication. Treatment goals for OUD should be individualized and do not include tapering for all patients. This was an important one because tapering came up both in the focus groups and in our visits time and again as something people were expecting to see happen. And we know from the guidelines that that is not necessarily the best practice for buprenorphine prescribing. So helping people understand that really individualized goals were important was a big part of what we were doing. And then the last one, my pharmacy creates a welcoming environment for people with opioid use disorder. I hope that that was real, that we really did increase that for people because that was another big goal for us, was that pharmacists would, be a little less stigmatizing and a little more welcoming to folks with OUD. Next slide.
All right, we have a chat waterfall or two. Would you like to lead this or shall I?
It does not matter to me.
Okay, let's dive in. Would you try this model or this approach, or have you tried this model? Y for yes, N for no, and question mark for maybe. All right, mini visits. What do we think? Seeing lots of Ys. The people like it. Excellent. If there's a question mark, feel free to share what you would want to change about it. So Kyle, you have a question mark for maybe. Feel free to either unmute or type in the box. What would make you turn into a solid yes? We'd love to know. All right, and I think we have one more chat. What challenges do you foresee in using this model? So what do you think might, and spoiler, Monica's going to tell you what challenges they had, but what challenges do you think would come up based on everything she's shared so far? So Jessica from the VA says time, of course, and the fact that these are short visits. What else do people think would make this model more challenging? Aaron says a unique situation requiring 4 sessions over a year. Adrian from Maryland says just participation, getting people involved. Time and the funds for traveling. I would throw that in there too. You're talking about 12 visits before you lose your mind. That's a lot. That's a lot. Katie says, I'm not a pharmacist, but I'm sure their salary is much higher than mine. Love the 5-minute detail though. Definitely good to do. Not reading material left if no actual contact. Narissa says covering the material in an engaging and thorough enough way with that short of amount of time. What do you think, Monica? Should we show them what actually came up for you?
Yeah.
All right.
So a lot of the things people mentioned, the big one in terms of actually shifting the dispensing was that corporate level barriers exist for pharmacies. So the P2P model is not designed to address that policy level barrier. We had one chain of federally qualified health centers that I think we had 5 locations among our 116 pharmacies, and they had just decided they didn't prescribe buprenorphine, they didn't dispense buprenorphine, they didn't carry buprenorphine in their pharmacies. So their pharmacists talked to me, they were welcoming, they had questions, but at the end of every conversation, they'd say, you really need to talk to Chad because he's the one that makes that decision. And I did try to talk to Chad. He got tired of hearing from me. But, ultimately that was not what our role was, to try to change that policy. And we were not successful in changing that policy. We also had some national chains that had like ordering restrictions and stuff that made it hard on their pharmacists. That those were the barriers they were bringing up, and we couldn't really overcome those for them. Staff changes and pharmacy closures. This was hard. There was at least one pharmacy I can think of where I saw the same person 4 times. And then on that 5th visit, they were like, oh yeah, she quit. She's gone. And I was so upset. And of course, that was when we were giving the post survey. So we didn't get to hear what she thought of us. But pharmacy closures, we had 3 pharmacies close during the course of the project. And I know a couple more of the pharmacies that we visited have closed since. So that is just stressful and hard to deal with for everybody involved. People brought up just how brief 5 to 10 minutes really is. We did a lot of rehearsing these visits. We would make the materials and then cut down the materials and then decide we're going to take that out and put it in a CE activity, or we're going to talk about that some other time. It's hard to have a meaningful conversation in 5 to 10 minutes. And so again, we're relying on those printed materials and making sure that we're being kind of responsive on a global level to what are we hearing a lot of, how can we build that into these next round of visits. Regulatory change, we kind of presented ourselves as experts, and then it was happening so fast even we couldn't keep up. The cards that we printed for the last round of visits were outdated before we finished the visits. So that was a challenge. And then, like people said, the time and effort required for that kind of universal approach. It was really good to visit every pharmacy in a county. It helped us really understand what was going on in the county. It helped us share information from one pharmacy that was doing really well with a nearby pharmacy that maybe wasn't quite on top of things. You know, this is how they're making it work. Here's how you can make it work. But it is time and effort intensive. Some days I felt like I drove for 6.5 hours and did an hour and a half of work. And that can be, you know, tiring and stressful. And then next slide. So if you're thinking of trying this, there are some tips on this slide. The 2 I would point to: using pharmacists or technicians with community pharmacy practice experience. I love an interdisciplinary program. I love working with my colleagues in other fields, but community pharmacy, there's something that's just unique about it. And Laura and I both were community pharmacy residency trained and had practiced as full-time staff in community pharmacy. And I think that really gave us an authenticity and an ability to empathize with the pharmacists that we were talking to in a way that other healthcare professionals might not have quite the same interaction. It's also really important to understand what their workflow is. So as you're like inserting yourself into their workflow, you know when to say like, go help that patient. I'm going to step back here and wait a minute for you. The other one I would point to is taking and reviewing really good notes to improve your efficiency. When you visit 10 pharmacies in a day, it's really hard to remember like who told me what last time and who works where. And so just having those notes and reviewing them every time I stopped the car, I would look at my REDCap report and see, what did we talk about last time? Who did I talk to? What's going on at this pharmacy, so that I could pick that conversation right back up when I walked in, as opposed to having the same conversation over and over and over again. And that was a lesson learned during the Healing Community Study, kind of the hard way when we realized, like, I don't remember if I've even been in this Walgreens before or not. So really good notes is probably the best tip I can give if you're going to try to visit a whole bunch of pharmacies in a day.
All right. Well, we're coming to the end of your talk and we have plenty of time for questions. Thank you so much, Monica. Would love to open it up in the chat, or to folks who would like to unmute, please do throw your questions into the chat box. Thank you so much, Monica. Really, really enjoyed your presentation.
Thank you.
Any first reflections from anyone? And of course, Monica, I love to ask this question. If you could go back in time, what would you do differently?
I would extend the project longer, because we were like doing visits, developing content, running webinars, like just on an incessant cycle. So I would have liked a little more time to reflect and to build up the content on a less demanding schedule.
It sounds like a very relatable desire across so many projects right now. Mike, I know you probably have a question, so I'll turn it to you while we wait for the chat box to fill up. Please don't be shy.
Yeah, I wanted to sort of riff a little bit. There was a question in the chat about, what might the pharmacy chains recommend, although, that environment's difficult. What we talked about in Finn's presentation a few minutes ago of that sort of bi-directional feedback. I am curious, Monica, to what extent, even though they do face these corporate constraints, do you feel like you're seeing, or were you seeing pharmacists get sort of activated in a way that might feed information up the chain as well? Or is the environment such that they're happy to see you, but it can't really go up?
Yeah, I think at least in the communities we were in for Bridge, it was a lot of independents. So not as much chain community pharmacies. The barriers that we ran into in the chain community pharmacies, we heard at multiple pharmacies, even when they were like in a different district in their chain. And so it was helpful to be able to say, like, oh yeah, the Walgreens in this town is also having that problem. And sometimes you would get like, well, their district manager told them that, and they're not communicating across stores, right? So we kind of could be that connector to say, here's what's happening at another store and how you might be able to help that. And sometimes I think it prompted them to like call their district manager and say, hey, what's going on with this? We did reach out, one chain, we reached out to somebody that we knew in their corporate structure and said, hey, we're hearing this from a lot of your stores. And it was a fruitful conversation, but I don't think it went much further than that one, kind of regional level. So I think having more connections in the corporate world would be helpful. Or I think somebody in the chat mentioned trying to have the corporation say like, hey, you have to do this, or you can do this on paid time, would be helpful. But again, I doubt it would happen.
We have two reflections. Well, one reflection and a comment. Darla Peterson from Iowa is sharing the difficulty of keeping everything straight, especially when clinics look the same. Trying to remember what the manager looked like, where their conference room was. So just some empathy there. And then Jessica from the VA asks, would you do a similar project again? And are there other topics you would consider in the future?
Yeah, so we're hoping to try to find funding to kind of continue this. One thing that came out of Bridge was a lot of interest in the injectable buprenorphine products and how pharmacists could be involved in that, which again has some regulatory barriers, but would be a really nice thing for rural community pharmacists to be able to administer or even just dispense to the clinics. So we've looked at that as a potential topic for future outreach. We also they just approved medical cannabis in Kentucky. And so we've been trying to figure out if there's a way. It kind of feels like this tsunami that's coming for clinical practice, all these patients that are suddenly going to admit that they're on cannabis, that they're using cannabis. And so trying to think about ways that we could maybe do a P2P program for pharmacists so that they're aware. I don't think pharmacists are even asking about cannabis right now. So, so that they're aware of what that means for people's drug therapy regimens.
Lots to think about. Well, thank you so much, Monica. We really appreciate you and keeping the through line of pharmacy going and innovation. Let's turn it over to Mike to introduce Megan Breckling, a longtime colleague of ours who will be rounding out NaRCAD 2025 and wrapping it up. No pressure, Megan, keep the energy up.
Yes, we are delighted to introduce this final presentation. And I know I've been joking about the bouncing around, but it really is wonderful. Within the U.S., all the different regions of the country that we've seen represented, and our first chiming in from Arkansas. So thank you, Megan, for being here from the University of Arkansas for Medical Sciences. That's where she is an ambulatory care pharmacy specialist. She did her academic detailer training with us at NaRCAD. It warms my heart whenever I get to say that about someone presenting at our conference. She works in the Center for Health Services Research at the university's Psychiatric Research Institute, and she's part of a multidisciplinary academic detailing team that includes a pharmacist, physician, and physical therapist, providing evidence-based solutions, tools, and support for chronic pain management. And that's a statewide program. So such a beautiful example of that multidisciplinary, cross-discipline alliances that we've been talking about throughout these 2 days. She's going to share with us about Train the Trainer, their ANET program for better naloxone education and access. Megan, bring us home.
All right. Thanks, everyone, for sticking with us this afternoon, and excited to be the last presenter. Just to let you know, I have no personal disclosures with what I'm about to present, and the project I'm going to be talking about is supported by SAMHSA, which is the Substance Abuse and Mental Health Services Administration. But the contents of what I'm presenting, of course, is based off of our UAMS ANET team and doesn't represent, SAMHSA's views. This is our ANET team here, and as Mike referenced, we do have an emphasis on the multidisciplinary team. The SAMHSA funding is a 5-year program, so we started out in October of 2023, and we are in our 3rd year now, starting in October, and we'll go through September of 2028. We have lots of people, lots of expertise on our team, a research program specialist, myself, a pharmacist, a physical therapist, who's Leah Toby Moore, who has presented before at NaRCAD. So she says hi to everyone. And then peer support specialist, Yolanda, Dennis Peoples. And so it's just great to have such a fantastic team. And it really, shows that having this team together is really what leads to the success that we've had. Specifically, our detailers, just to point out, is myself, Leah, and Yolanda. So we're the ones that have gone through training and are leading the detailing effort. So let's talk a little bit about what our evidence-based practice that we are promoting in our detailing program. So just to give you a view, we all know that the opioid epidemic is a major public health crisis. But here in Arkansas, it's particularly concerning because 40% of our population lives in rural areas. And that's, a lot more than the 15% of the US population. So we have a lot of challenges with prevention and treatment access. And we know that those rural areas experience overdose rates at a higher rate than urban areas. So that's why it's really important we get these practices to the providers there. Another thing to note is that Arkansas is actually #1 right now for prescribing opioids. So that's definitely not where we would like to be, but it shows that we need to do a lot of work in this area. Our prescribing rate is around 78.5 prescriptions per 100 people. A few years ago, I like to highlight, we were over 100 per 100 people. So we are making strong efforts to decrease our prescribing, and I do feel our education to providers has been part of that effort. Another thing to note is that we've had in 2022, we had 537 drug overdose deaths, and 70% of those involved in opioids. So that includes both our prescription opioids and our illicit fentanyl. So that's why this program has really focused on how we educate people about both of those types of opioids and how these interventions can be helpful for those. Another thing that kind of supports why we are educating about naloxone is that almost half of these overdose deaths, there was a bystander present. So there was somebody that could have administered naloxone if they understood what it was for and how to administer it. So we're hoping through education that we can improve overdose deaths and mortality and get people the help that they need. If you don't know, naloxone is an FDA-approved medication for respiratory depression from opioid overdose, and that is normally what leads to death. So it reverses the respiratory depression and allows that person to live and get further help. There is lots of literature out there supporting opioid overdose education and naloxone distribution. So if you look up OEND in the literature, you will find many things supporting its evidence-based practice. It improves knowledge for people that receive the education. It helps with their attitudes towards naloxone, feeling more confident in response. And then it also reduces opioid deaths, which is the ultimate goal. And as I stated, our program is really focused on trying to reach those rural and underserved communities, since that is the majority of our state. So one of the techniques that we are going to talk about today is the train the trainer approach. If you could go to the next slide. This is kind of one way to look at it. And per the CDC, they call it the training of trainers, so TOT model. And the purpose of this is to build a capacity of prepared expert trainers to go out and then train others. It really is focused on expanding your program reach. So if you've been thinking about ways that you could maybe reach a higher volume of people, this might be something you could look into. Basically, I'll kind of get into the flow of how our program worked, but the way that the approach works is that there are some lead master trainers that, are trained in detailing facilitation skills, and they go and they coach new trainers to deliver a consistent, high quality education. And you normally have a target audience that you're hoping that they'll reach. There's a lot of adult learning principles and interactive methods, practice sessions with feedback, action planning and follow-up support. We also make sure that we have, effective communication with our trainers. We facilitate and we make sure that we are meeting their personal needs as you would with an academic detailing visit. And we are very adaptive. So we, of course, are making sure we're adapting our materials based on the need. The other model, which is on this next slide, is the TWI Institute model. So just another way to kind of vision what this TOT model is. But ultimately, we're just trying to prepare champions to go out, deliver training, and to make that training effective. And then we are offering that follow-up and support because we know, oftentimes it doesn't quite go, 100% the first time. So we meet back up with them and see what barriers they're having and how we can further support them. So the next slide is showing, oh, we have a chat waterfall. Perfect.
Surprise. All right. One of the last ones of the day. So do it some justice. The most difficult part of teaching a new concept to an adult learner is, think about this while you're detailing, think about it while you're telling your adult son something, think about it while you're telling your parents something. What is the most difficult part of teaching a new concept to an adult learner? Vishal says getting past the I already know that mentality. Adrian says adapting to change, retaining the knowledge in the process, the hard-headed. I love that, Donetta. Just they're hard-headed. No one likes advice, preconceived bias, everyone's multitasking, assessing their comprehension, the need to unlearn something first. We love that. Inertia, being stuck in their ways, helping them unlearn once again, helping them unlearn what they think they know. Assessing prior knowledge, not dumbing it down or speaking over their head. And Daniel says all of the above, along with learning what their specific learning style is, getting their attention. Whew, there is a lot going on there. So just some things to think about when we're talking about the work we do as detailers, and then also learning how to teach, being taught how to teach. Just an interesting thing to think about. Back to you, Megan.
Yeah, thank you for all those helpful comments. And yes, I agree. You're always changing the way that you're teaching others because we all learn in a variety of ways. So kind of tailoring that is really important. So this is kind of how we took the training of trainers approach here at ANET. So you can see it's kind of a hierarchy of how we're using our knowledge to disseminate to the community. So we have our program team that has 3 academic detailers, myself, Leah, and Yolanda, that are training our registered trainers. So we are using academic detailing principles. We conduct needs assessment with these trainers. We identify and prepare them to go out into their individual communities. And we make the training dynamic. So it is not the same for each person. We make sure that we talk to them about what barriers they're worried about and helping to address those. And then they go out and they train their community, and that community could look very different for each trainer. It could be in a pharmacy setting, it could be in a treatment facility. So we talk about that during our initial training with them of who do you think you'd like to educate and what barriers do you think would come up? And so it just kind of shows that you can get a larger reach by kind of tailoring that initial training with them. We also host trainer quarter meetings. So each quarter we get all of our trainers together. And we really talk about, what's going on with different trainers, what barriers are they having, what went really well in their classes, and we try to share updated local knowledge with them as well. So if new data came out, or if we've heard, you know, a lot of trainers wanting some education on a certain topic, we share that. And we do a lot of technical assistance just as being our main hub here. So it's really cool to kind of see all the trainers come together each quarter and kind of bounce ideas and give support to each other. So the next slide is going to show you kind of the flow of how our data collection and the program works, which I'm a very much a visual person. So this was how we had to lay out basically where we were collecting the data. So up at the top, you have, this is our trainer data flow. So they start out by, of course, registering for our program. They take a initial naloxone knowledge and attitude survey. And then they have training with us. That's the detailing part. So in the blue there. And we have 3 modules that we cover with them. So each of those has key messages and important objectives that we're trying to meet. And again, there's a lot of discussion involved with those and making sure we're addressing personal needs. We also offer CE, which is a great incentive to give for academic detailing visits. And then following that, they do a post survey. So we collect again their knowledge and attitudes and also evaluation of our training to make sure we can improve it. Following that, they meet with us quarterly, like I said, for those 4 quarter meetings. We have a survey that goes out to them that, you know, checks in to say, you know, how's it going? What barriers are you having? How can we support you? And then we kind of take that data and we talk about it during the meeting that we have with them. So we also give them gift cards for each of these kind of initiatives and goals that they reach. And then also we hope that they deliver at least 2 classes per year. That's their goal in their community. And it can be anyone from just 1 person they train up to, we've had 100 people trained in 1 class. So, you know, quite a variety of what that looks like. And we do give out free naloxone kits. And I feel like that's been a really strong part of our program because a lot of these trainers, they're very passionate about educating about naloxone. But their biggest hurdle is they don't have access to free naloxone. And we know it can be pretty expensive for people that are needing it. So we have been able to offer that, and that's been a really good incentive. On the next slide, we're going to look at the community side of things. So we also gather data from our community participants. It's a little less intensive, as you can see, but we're doing a similar thing where we do the pre-class knowledge and attitude score, and then they have the class with the trainer that's gone through, you know, the training with us and is a certified trainer to give the class. And then afterwards, they take another survey, and we're kind of comparing those scores. And then we also send out a 1-month follow-up to kind of check in. Some of the questions we ask is, did you use the information that was provided? If you needed treatment, did you go ahead and engage in that? Did you use the naloxone kit? Do you need a refill? So some of those things we ask to our community participants so that we can kind of follow up on those further outcomes. And we have kind of talked about 1 month may not be quite enough view of kind of what's happening. So we're already talking about how we could look at that a little bit more longitudinally. So being in the Center for Implementation Research here at the College of Pharmacy, I have been trying to embed some more implementation frameworks. So we've kind of heard earlier today from programs that are using some of these frameworks. So you guys are maybe familiar with them, but CFR is the Consolidated Framework for Implementation Research. And it can be used in various parts of implementation. You can use it before you implement something, during, or after. So we've kind of used this framework throughout our process to kind of look at the different domains and constructs that are influencing whether our trainers can do the classes that we are hoping they can provide. So we look at intervention characteristics such as, you know, what they like about our program, what they dislike, what could be better, what's influencing them outside, the patients they're dealing with, the process. So definitely if you're looking for a framework to kind of look at those things and maybe even do some qualitative interviews, it would be a great framework to look at. And the other one we've heard about already today was REAM. So It's a great one to use to kind of think about your different measurements in the reach, effectiveness, adoption, implementation, and maintenance phases. So this is something that we're using kind of each year to kind of look at where we're meeting these metrics and where we could improve. So just to give you a look at how we're doing, so I mentioned we were just starting year 3. So when I made these slides, this was kind of right at the end of year 2. So we were able to meet some of our goals that we were hoping to meet for year 2. And one of those was to have at least 50 active trainers. So we had 53. Those trainers delivered 75 classes total. We were hoping to get 100, so we were just shy of that. And we were hoping through those classes we would reach about 1,000 Arkansans, and we got 743 around. So I'm pretty proud of the successes we've had. You can see from year 1 to year 2, we made big strides and jumps, and that just kind of shows that this train the trainer model, it multiplies. So like as you're going through the years, you're really able to see those numbers expand and multiply pretty quickly. So if you're needing to try to increase your reach, this would be a great technique to try. Give you a little bit more data. So we have done an initial evaluation for our first year. So this is a little bit delayed because this data only goes through May. We're working on updating it now. But at that time, we had 34 trainers, and they came from a variety of disciplines. We had pharmacists, peer support specialists, community healthcare workers, nurses, also healthcare professional students. So many different people that are passionate about naloxone training, and they were working in a variety of settings. So they were in treatment centers, clinics, pharmacies, even in carceral settings. So lots of different communities that were reached. One of the things that we did to make sure that we were hitting some of the high risk groups in Arkansas is we put counties into priority groups. And those were based off of the opioid overdose data from the Arkansas Department of Health. So we used the 2021 data because when we wrote the grant, that was what was most current. So we put them into priority groups to try to recruit trainers from those high risk counties. And as you can see, our highest group with the highest risk, we have the most trainers. So we're doing a good job. We're kind of looking at, how we can kind of even this out based off of risk. We're also going to use the most updated data to kind of redistribute the counties if we need to as we move forward. I mentioned earlier those pre and post knowledge and attitude scores. So you can see for our trainers, we had an increase in knowledge. So around 38.7 to 41.6, so almost a 3-point improvement there in their knowledge. And we knew this would be smaller because a lot of these people probably have had naloxone training, know a little bit more about it, but it was still cool to see that we still improved their knowledge. And then we also had some attitude improvements. So competence, concern, and readiness, all of these improved. So this is a big part of making sure people feel confident in going out and delivering this education. And then the next slide is going to show you the community side of things. So you can see up to May, we had 210 community participants included in ANET. We had a similar change in knowledge, a little higher, so a 5-point improvement. Majority of people were from that high risk group 1, which, makes the connection of if you have the trainers in those areas, you would hope they're training the community members. So that was a good connection there. And then our attitude scores also were positively impacted. So it just showed that, the training that we're giving to trainers is getting to the community members. So that was kind of validating that this education is effective. And with that, I will see if anyone has questions. And of course, if you want to email me, I'd be happy to answer that too.
Thank you so much, Megan. And y'all will see that any of the frameworks or models that Megan brought up are all in the chat, and you will receive those via email if you'd like to geek out and get deeper into the implementation frameworks. Really great stuff. Questions, please pop them in the chat. We'd love to wrap up with some thoughtful questions or reflections as day 2 comes to a close. Mike, I see you're unmuted. I know you always have a question, so I'm going to throw it to you.
Yeah, Megan, I'm interested as you've pursued this effort, and I'm making an assumption. I'll acknowledge I'm making an assumption here that um, about the sort of the environment for like naloxone distribution from, free from pharmacies, standing orders, distributed from, all kinds of places. Because there's a wide range. There are places that just sort of push naloxone out to everyone with minimal barriers. So I'm curious what you've identified. I mean, these were great results that you showed with the people who engaged, but I'm curious, are you sort of seeing traction in the community as people start to say, oh, this is important to make it more widely available, that sort of public argument as well?
Yeah, been doing some detailing since 2021, and I've seen some positive improvements since then. I do feel like the public is starting to understand that there is a wide range of when naloxone could be needed. And I think that goes back to our training as we tried to tell our trainers that, you may be educating a family member of somebody that's prescribed an opioid, or you may be educating someone that is worried about someone that's misusing or using illicit drugs. And the way you talk about naloxone needs to change based off of that scenario. So we do a lot of kind of practice with that. And specifically pharmacists have kind of come up. So talking to them about, it's not going to be the same way you always talk about. You may call it, a fire extinguisher. You hope you never have to use it, but it's there if you need it. So like kind of using those different ways of talking to patients, because there's a lot of stigma around the topic, and the way we talk about it can kind of change that. So I think it's been positive to see the change. I think we still got some work to do, but.
Thank you, Megan. Any final questions for Megan? Thoughts or reflections? Thank you so much. What a wonderful way to close up. Really appreciate all of you who participated today.